As 8 children who should get the drugs first. It was really a difficult situation in those days. Fortunately, we've gone way past. And I think this is a time for us to take a step back, reflect. What have we done? What are the achievements that we've been able to make? What are the lessons that we have learned? And then also prepare us for the future. Because again, if you look at treatment, and this will come through the presentation, treatment has really, really evolved. And as a country, we need to strategize. So this is really coming at an opportune time so that all of us can put our shoulders to the wheel to make sure that we are able to improve access, we are able to deliver a sustainable HIV program. With these few words, I really want to say I accept to chair the function, and I look forward to a very fruitful engagement with all of you. Thank you very much.
Let's do it better for our chairperson. Thank you for accepting to steer the affairs of this meeting for us. And I'll move on to introduce other dignitaries who are here. From the Directorate of Nursing and Midwifery Cancer Service, we have Mrs. Eva Mensah here. Yes, who is the director of that division. Then we have Professor Alexander Manu, consultant for triple elimination, also here with us. Thank you for coming. Then we have over 1,000 online participants, most of whom are health workers. You are also welcome to this meeting. Thank you so much for registering to be part of this meeting. On this note, I'll call on the Director of Public Health, Dr. Franklin Essien-Dubequin, to give us the purpose for this meeting. Please help me welcome.
Thank you very much, Jacob. The Director General of the Ghana Health Service, Dr. Patrick Kumar Abwaji, the rep of the Ghana AIDS Commission, the country rep, UNOPS, development partners, Society for AIDS in Africa, reps for NAPLAS, the community chair, academia, directors and staff of MOH and Ghana Health Service and other ministries, program managers, HIV technical working group members, the media, ladies and gentlemen. It is an honor and a privilege to stand before you today as we convene for this significant event, the National HIV STI Dialogue Series, under the theme 20 Years of HIV Antiretroviral Therapy Treatment in Ghana, celebrating progress, advancing research, and ending the epidemic. This gathering reflects the commitment and resilience that have shaped Ghana's public health response over the past 2 decades. Today, we commemorate not just a milestone in time, but in our achievements. We recognize the crucial role that researchers, health practitioners, and dedicated institutions have played in propelling Ghana's journey towards controlling HIV. Through cutting-edge research, our knowledge of HIV has deepened, informing evidence-based interventions and treatment models that continue to save countless lives. It is because of this advancement that Ghana has seen an encouraging decline in HIV infections and a substantial increase in treatment coverage. These improved statistics are a direct result of our collective commitment to a healthier nation. Yet, our journey is not over yet. The purpose of today's dialogue is to celebrate, but also to reflect, to strategize, and to improve our commitments to ending the epidemic. As we advance, we will deepen our focus on research, community engagement, equitable access to treatment and prevention, ensuring that we have behind. Together, part not only honors our achievements, but carries us towards the elimination of HIV as a public health threat. Thank you all for your partnership and dedication, and we look forward to the impactful discussions that will utterly emerge from the meeting. Thank you.
Thank you very much, Public Health, for that. So we'll take some messages from our partners who are here. More particularly, read from WHO, from WHO. Please help me welcome you. While she's coming, our washrooms for the countries are just behind the WHO banner. Then, if you are also at the washroom, you can access it just at my extreme back of the hall, just at the my website. You can go and use the washroom over there. Thank you.
Good morning, Mr. Chairman. The Director General of Ghana Health Service, the Director for Public Health, the UNOPS, program managers and directors, head and representatives of society organizations, esteemed colleagues, researchers, healthcare providers, and advocates. Ladies and gentlemen, today we celebrate the progress we've made, driven by the resilience of those living with HIV, the dedication of healthcare professionals, and unwavering support of our partners. We also recognize the critical role of research in enhancing our understanding and treatment of HIV, paving the way for innovative solutions and improved outcomes. Let me start with a story that embodies the spirit of a young woman named Ako, diagnosed with HIV 2 decades ago, faced immense challenges and stigma. Thanks to availability of antiretroviral treatments, she not only survived but thrived. She pursued her education, beauty career, and advocates for others living with HIV. Her journey from despair to hope is a powerful reminder of our health. As we reflect on our achievements, let us also renew our commitment to advancing research and ensuring equitable access to treatment. Together, we can build on our successes, address the challenges, and move closer to ending HIV in Ghana and beyond. Over the past 2 decades, Ghana has made remarkable strides in expanding access to immunity, scaling of HIV prevention programs, and reducing burden on HIV/AIDS. This conference provides an invaluable platform to reflect on this achievement, acknowledge the tireless efforts of healthcare workers, researchers, and community members, and celebrate the resilience and courage of people with HIV. As we gather here today, we must also recognize that the fight against HIV/AIDS is far from over. Challenges continue to emerge, including the rise of drug resistance, for innovative prevention strategies, and the ongoing stigma and discrimination faced by people living with HIV. This conference will delve into these critical issues, exploring the latest research findings, sharing best practices, and discussing strategies to address the evolving needs of our communities. We will hear from renowned experts, engage in thought-provoking discussions, and collaborate to chart a course towards ending HIV epidemic in Ghana. I encourage all of us to actively participate in sections, share our knowledge and experiences, and foster collaborations that will drive progress in the years to come. Let me end by sharing a research question. Perhaps the office can work with whoever comes up with a good research proposal to answer the question. Despite the wide adoption of global best practices and innovation by Ghana, the country's progress towards the UN's targets remains slow at 65, 69, and 89. What can we do to change the narrative? Together, let us renew our commitments to ending the HIV pandemic in Ghana. Let us celebrate the past, embrace the present, and shape a future where HIV is no longer a threat to our health and well-being. Welcome once again, and I wish all of us a productive and inspiring research dialogue. Thank you.
Thank you very much. We're from the office of the WHO in Ghana. Let's put our hands together once again for her, for those remarks. So I invite the rep from Ghana AIDS Commission to also give us a message. Please help me welcome him.
Mr. Chairman, distinguished ladies and gentlemen, please permit me to stand on existing protocols as I bring you one witness from the Ghana AIDS Commission and share a message on behalf of the Director General. When cholera broke out in England in 1854, the father of modern epidemiology, Don Snow, researched the problem by using statistical mapping methods to understand the sources and spread of cholera. His research findings saved England. In 1928, Hideo Noguchi died of yellow fever while conducting research in Ghana. To commemorate this great scientist, the government of Ghana decided to construct in Ghana a palatial edifice for HIV, for medical research and manufacture of vaccines for Ghana and all Africa. All expenses paid. Noguchi Memorial Institute for Medical Research, as it stands today, is a sad reflection of the original vision the government of Japan had for the people of Ghana. What happened? When COVID-19 struck the shores of Ghana on 12 March 2020, we all put points down on pandemic preparedness. And then our Noguchi Institute did so well then, but could have done far better for Ghana and Africa if the original vision had blossomed. For Chairman, we all know the relevance of research, but what premium do we place on research in allocation of statutory resources? The fruits of research have transformed HIV and AIDS landscape by replacing the obituary of all recipients of care with a certificate of hope. But far more than any other person in this room, I am highly elated that at the epicenter of the ART at 20 celebrations, a research dialogue has found its rightful niche. Ladies and gentlemen, Impaya Dia Osai, Ghana Health Service Dia Osai, School of Public Health Dia Osai, NSCP Dia Osai, said Dr. Stephen A. said ACE Dia Osai. As the best brains in the country gather today to dialogue and reflect on using research findings to inform and design the national HIV response, I wish all of you fruitful generations as we chart a new course to eliminating HIV and AIDS as a public threat by 2030. Thank you.
Thank you very much, Mr. Jare, Rep from the National Ghana AIDS Commission, for that message. Please, let's put our hands together for you. So I'll call on the Rep from Napolas to give us a message. Please help me welcome her with a round of applause.
Mr. Chairman, distinguished guests, esteemed colleagues, fellow advocates, valued participants, ladies and gentlemen. It is both an honor and a privilege to stand before you today as we gather to celebrate the remarkable achievements of ART at 20 initiative and to engage in a meaningful dialogue about the critical role of research in shaping our HIV programmatic interventions in Ghana. As persons living with HIV, we face discrimination, social exclusion, and marginalization. This stigma perpetuates harmful community perceptions about ART and HIV, hindering effort to scale up treatment and prevention. However, after the PL-HIV stigma index 1.0 in 2014 and 2.0 report, which was released last year, we, the PL-HIV, who took the lead in this study, conclusions and recommendations we made saw through our research that we had to work on ourselves first in order to address other stigma. We have stated and have achieved and continue to claim our spaces, which stigma and discrimination has scared many of us from stepping in and participating meaningfully in the growth and development of our community and country. I want to emphasize the profound impact that research had on our lives and the lives of the infected and countless individuals affected by HIV. Over the past 2 decades, we have witnessed significant advancements in ART and pre-exposure prophylaxis, which has transformed HIV from once seen as a deadly disease into a manageable chronic condition. These medical breakthroughs have not only improved health outcomes, but have also empowered us to live full and productive lives. However, as we celebrate these advancements, we must also confront the persistent challenge that remain. Stigma and discrimination continue to be formidable barriers to accessing care and support. Many individuals living with HIV still face societal judgment, which can deter them from seeking the treatment they need. It is crucial that we address these issues hand-on, fostering a community that embraces understanding, compassion, and acceptance. Today's dialogue will provide us with invaluable opportunity to explore community perceptions surrounding ART and stigma associated with HIV care. We must listen to the voices of those directly affected, as their experiences and insights are essential in guiding our research and interventions. It is only through collaboration and open dialogue that we can develop effective strategies to combat stigma and enhance the quality of care for individuals living with HIV. I would like to urge all stakeholders present today, researchers, healthcare providers, policymakers, to prioritize community-centered approaches that address stigma and promote inclusive, accessible HIV care. I urge community advocates to continue bringing out issues to the fore, using the just revised community-led monitoring tool to obtain evidence and data based on which we can have and work together to bring innovations on board in the spirit of partnership. Let us commit to using the findings from our research to inform our practices, shape our policies, and ultimately improve the lives of those we serve. Together, we can create an environment where everyone feels safe, supported, and empowered to seek the care they need without any judgments. I would like to express my gratitude to the Ghana Health Service for organizing this important dialogue and for their unwavering commitment to improving health and well-being of all individuals living with HIV. Let us move forward to determination and hope, knowing that our collective efforts can lead to a brighter future for our communities. Together, we can bridge the gaps in HIV research and the community engagement. Together, we can end AIDS as a public health concern. Thank you very much.
Thank you very much. Now, plus, let's put our hands together once again for them as they take their seats. I will invite the rep from UNAIDS, Madam Eunice Mensah, to give us a message. Please help me welcome her.
Good morning, everyone. Mr. Chairman, distinguished guests, permit me to stand on existing protocols. I am deeply honored to deliver these remarks on behalf of Mr. Hector Susila Perez, the UNAIDS Country Director, who is currently out of the country and is unable to be present at this meeting. He sends his warmest regards and his deep appreciation for today's gathering. Before I start, I just want us to reflect on the fact that this is an important moment because data drives the work that we do, research drives the work that we do, evidence drives the work that we do. And as a moment, it's not just an event, but it's also a celebration of our shared commitment and our unwavering dedication to advance the fight against HIV. Today, we come together as partners, we come together as advocates, we come together as champions bound by a common purpose to harness the power of research to transform lives across Ghana. Our work today, the deliberations we'll have today, is a testament to our shared resolve to drive forward innovation, community engagement, and compassion in our national HIV response. Research is the lifeblood of this mission. Through groundbreaking inquiry and tireless dedication, we have achieved and can continue to achieve remarkable strides on different areas, on ART, on PrEP, on community-based interventions, on HIV-related stigma and discrimination. Each new discovery offers us a beacon of hope, a promise for better health and better future outcomes for those living and affected by HIV in Ghana. We have seen the impressive results of a collaboration between Gilead Sciences and Merck, showing the importance and potential of long-acting treatments to sustain viral suppression for longer durations. And if some of you have been following the news, there is a potential for us to have ART medication just taken twice a year because it's long-acting. When do we get these drugs in Ghana is the question I ask, and how do we advance the work on the ground for us to be able to also touch the lives of those living and affected by HIV in this way? This advancement holds profound implications for our efforts to simplify and to strengthen HIV treatment. They are not just scientific milestones, they are lifelines for individuals, families, and entire communities who have been touched by HIV. But as we celebrate these scientific achievements, we are reminded that our journey is far from over. Stigma and discrimination remain formidable in the barriers to progress. Studies like the Ghana Demographic Health Survey, the Stigma Index study, reveal the very real challenges that individuals continue to face. These barriers are often invisible, but nonetheless devastating. Addressing these challenges is not just a matter of science, it's also a matter of humanity. Only by breaking down these barriers can we truly provide a path forward for everyone affected by the HIV response. As the Joint United Nations Programme on HIV and AIDS, we are standing and remain committed to supporting Ghana's HIV research efforts and to working closely with all our partners here today. Together, we can advance a research agenda that prioritizes not only innovation, but inclusivity and compassion. Let us build a future where every person, regardless of who they are or where they come from, has access to treatment, care, and the support they need. In closing, I truly urge each of us to hold fast to the vision that has brought us together. May we be inspired by the stories of resilience. May we be inspired by the stories of courage. May we be inspired by the strength that echoes through our work. Let those stories remind us of why we're here, and let us renew our commitment to an HIV response that leaves no one behind. Thank you all for your dedication, for your commitment, and we look forward to insightful discussions and shared learnings. Thank you.
Thank you very much for that remarks, Wendy's. We've reached a very important part of this dialogue meeting, which is the keynote address. But before I invite our keynote speaker, who is also the host, let me give this announcement. Immediately after his speech, please all poster presenters are supposed to be by their posters so that we can go and open the poster presentation. Thank you. So on this note, I will invite the host of this dialogue, the Director General and also the keynote speaker, Dr. Patrick Kumar Abuade.
Thank you very much and good morning. Thank you for joining us for this very important event and a landmark meeting that we're having. Professor Chair and also the Dean of the School of Public Health, Professor Kofi Tope, the representative from the Director General of the Ghana AIDS Commission, the Director of Public Health, Dr. Frank Nesilis Bequin, reps from the UNOPS and other UN partners gathered here, rep from UNOPS, NAPLAS, our committee chairman, academia, our online participants, program managers here, ladies and gentlemen. It is indeed an honor and privilege to stand before you today at the launch of the National HIV/AIDS Dialogue Series. As we gather under the theme 20 years of HIV antiviral treatment in Ghana, celebrating progress, advancing research, and ending the epidemic, we recognize not only the milestones we have achieved together, but also the urgent path ahead towards an ending HIV in Ghana. Today's theme captures both the significance of our journey over the past 2 decades and the determination with which we must look towards the future. 20 years ago, HIV was a life sentence, a death sentence, I would say. It tore through communities, destabilized families, and presented challenges that sometimes seemed unsurmountable. However, through the commitment of the government, the dedication of healthcare professionals, the resilience of our patients, and the unwavering support of our partners, we have made remarkable progress. Prof. Chair, as we celebrate these achievements, we must also be reminded that our work is far from over. The need for sustained efforts to advance research, expand preventive measures, and reawaken awareness is critical. Ladies and gentlemen, to eliminate HIV, we must continue to rally the energies of every sector, every community, and every person. First, let us reflect on our achievements. Over the last 20 years, we have seen the life expectancy of people living with HIV increase significantly due to antiretroviral therapy. Treatment access and adherence have saved countless lives and allowed many to live healthy and productive lives. But this success has also required sustained partnership, financial commitment, and a strong national health infrastructure. Today, I call on all of us, both within and outside the health sector, to continue supporting Ghana's progress in ART access and to invest even further to reach every corner of the country. Secondly, we must prioritize the prevention as a pillar of our strategy. Ladies and gentlemen, prevention remains the most effective and sustainable way to end this pandemic. As a country, we must invest in high-impact prevention strategies, from pre-exposure prophylaxis to increase access to condoms and safe sex education. Prevention, however, is critical and sustainable intervention. It includes community education and empowerment. We must make it a collective responsibility to protect the young generation from the risk of infection. For this, I urge our partners and stakeholders and government agencies to not only continue their support, but also expand investment in innovative preventive strategies. Let us also unite our awareness and re-energize our communities. Over time, the visibility of HIV awareness has diminished and complacency has crept in. But the fight against HIV demands renewed energy and vigilance. This dialogue series is an essential platform for reawakening public awareness and mobilizing communities to eliminate stigma and misinformation. It is also time for the national movement, one that encourages every Ghanaian to be vigilant, informed, and active in the fight against HIV. We must utilize the media, community programs, and digital platforms to bring HIV back to the forefront of our public health efforts and discussions. We must promote self-testing as a game changer. In recent years, self-testing has emerged as a powerful tool, offering people the opportunity to know their status in the comfort of their homes. Self-testing can break down barriers such as stigma and fear and reach individuals who might not otherwise engage with traditional testing services. To scale this up, we must create a supportive environment, increase access, and educate people on its benefits. So we call on all partners to help make self-testing widely available and affordable, especially in rural and underserved communities. Ladies and gentlemen, finally, we need more research, and we need it now. Research drives innovation, and innovation will drive us towards the ending the epidemic. We must be relentless in exploring new and better ways to prevent, treat, and ultimately eradicate HIV in Ghana. This means that we are strengthening our research infrastructure, and I must say, the Ghana Health Service is working towards establishing 2 new centers in Western North and Savannah to boost the number of research centers we have. We must also support our researchers and invest in studies that will answer our most pressing questions. In particular, we must focus on locally driven research to ensure that our approaches are tailored to our specific context and the needs of our people. Prof. Chair, today as we celebrate, it's a celebration of progress, but also a call for action. The road ahead demands even greater commitment, and the stakes have never been higher. We must strengthen our resolve to advance in treatment, prevention, research. And I urge every partner present today, health professionals, policymakers, NGOs, international agencies, academia, community leaders to play their role in this dialogue, not just today, but every day. Let us unite in purpose and unwavering in our dedication to ending HIV. Together, I am confident that we can eliminate HIV in Ghana, one community at a time. Let us make this generation the last to live with HIV. Thank you, and let us move forward with strength and determination.
Let's put our hands together once again for our female speaker, who is also the Director General of the Ghana Service. We have in our midst Mr. Ernest Ottin, who is the President, Garnet, a civil society group that has been supporting the AIDS fight in the country. Please, let's see you. Thank you for coming. So from here, we are all moving to take a group picture outside. The ushers are just at the entrance. They will lead us to where we are supposed to take it. After which our dignitaries will lead us to also open the poster presentation. Then we'll take our snack and come back to continue. We are doing this in about 45 minutes. So please, let's take note of that. So let's wait for our dignitaries to take their lead whilst we follow them to where we are taking their group pictures. Thank you. Those online, so give us 45 minutes. We'll be back with the rest of the agenda. Stick and stay with us. Thank you so much. database. So please, whilst they are presenting, if you have any question, just put them down. The moderator will give room for all of us to ask our questions. And I'll plead with all of you to stick to time, especially the presenters as well as the moderators for the session. So I have the singular honor to introduce our chairperson for the first session. Our chairperson is an infectious disease physician and dermatologist at the Kolebu Teaching Hospital. He's a physician with a specialist training in infectious disease and dermatology, and also experience in managing patients with HIV and co-infections. She was head of the infectious disease unit of the Kolebu Teaching Hospital from 2004 to 2014. She was the second person in Ghana to prescribe antiretrovirals, the first being Professor Alfred Robinson Igwe in 1998. She was a consultant for FHI 360 STAT, which rolled out the program Access to ART in 2003. At a point, she managed the largest single HIV treatment center with a patient population of over 20,000. I think she deserves a round of applause for this. She was also the head of the Department of Medicine from 2014 to 2016. She has worked extensively and closely with the National TB and HIV control programs to produce various guidelines for the management of the two diseases. She has also been very instrumental and involved in the training, monitoring, and supervision of various aspects of HIV and TB programs, and have also worked as a consultant in the development of HIV policies and HIV strategic plan for Ghana. She has been involved in the organization of local and regional HIV conferences. Her research areas include the skin and HIV co-infection, pharmacokinetics and pharmacogenetics of efavirenz in co-infected persons, HIV drug resistance, HIV-associated behavior, that is adherence, stigma, disclosure, employment, adolescent engagement with health sector, HIV in pregnant women and outcomes, and elimination of mother-to-child transmission. Distinguished ladies and gentlemen, our chairperson is a professor at the University of Ghana and was the past dean of the University of Ghana Medical School. I present to you Professor Margaret Lati. The audience.
Thank you. And thank you. It's my pleasure to be the moderator for this session. I mean, I stand here extremely proud because we were there when it all started. I don't know how many in this room. Can you raise hands, those who were there when it all started? Yes, so some of us were there when it all started. And as has been said over and over again, we've come a long way, but there's still a lot to do. I remember my first patient in 1998. It took me about 8 months to get the drugs. And I read it in the book. The first patient I put on treatment, the whole night I didn't sleep because I was expecting side effects that the patient would come back. The following night I slept a bit. Then by the third night, I could sleep. But now, our drugs should barely have side effects. And as has been said, we also work hard for the public access to antiretroviral therapy as part of the public health approach, the program for which we are celebrating. Let me share a little story and then we'll go on. A little experience I had a couple of weeks ago. So I had a client, a male client. And like the physician I am, I asked him, how can I help you? Then he said, they say I have HIV, so I've come for treatment. And I said, oh, is that so? Okay, let's have a conversation. Then he said to me, what conversation? My wife went to antenatal, they said she had ART, HIV. They gave her treatment. What conversation? Me too have come for treatment. Now, having worked in HIV for a long time, Steve, that tells you that what? Treat and test. It's working. So she went for antenatal, and the same day, she was given antiretroviral therapy. And then me, I'm saying that we should have a conversation. But I persevered, and we had a conversation. And at the end of the day, here were the missed opportunities. So the wife had gone for antenatal, she had tested positive. She was given treatment, but the missed opportunity, there was no couples counseling. So he wasn't tested. And she had gone on. The baby was now 4.5 months old. So I don't know what time in that later he couldn't tell, but let's assume for about 6 months he may have been positive and wasn't picked up. But as the conversation went on, I realized apart from the baby, they had 2 other children under 5. So for me, it was another missed opportunity. Pediatric HIV. Missed opportunity for finding out what the status of those children were. So as has been said, we've come a long way. And we are even going further. We have heard about twice a year, treatment and all that. But we still have to look back. What are we missing? What are the missed opportunities? How can we improve the 65, 69, 89? So there's more work to do. Some of us are ready to hand over the batons. Those of us who were there, we are ready to hand over the batons. But we want to encourage everybody else, get on board and let's work towards elimination of HIV. So now it's my pleasure to introduce my first speaker. I just call him Kwesi, Professor Tope. So you've heard a lot about Professor Tope. From the beginning, he was there. He's not God. He was there from the beginning. And then from here, he went international. But at the point we were chatting, he says, I want to come back home. I said, come, we need you here. And so Professor Tope came back. Those of you who came late, you missed the glorious introduction. I'm not going to go through all of that. You have to refer to the meeting meeting notes. But Professor Tope is still actively working in HIV. He leads another conference, interest, and many other things. And he's here to tell us about new things as we work hard to eliminate HIV and also try and improve on our output so that we improve the 65, 69, 89. Let's welcome Prof. Tope. Please write any questions you have down and then we can discuss at the end. And the online audience, you are also welcome. Please write any questions you have in the chat box or the Q&A and then.
All right, thank you very much, Prof. Nate, and then once again. So it's my pleasure to discuss with you the evolution of antiretroviral therapy, the state of the science. This is a very technical presentation. I thought I'll try and make it a conversation so that at least we'll all have something before we leave. So, introduction of antiretroviral therapy, like we said, we started in 2002 when Family Health International was able to secure funding from their corporate, the board, and actually had resources for 100 patients. So these were the 2 sites, Atwa and then St. Martin's in Agomaya. Now, if you look at that time, we had drugs for only 100 patients. So basically, you see that the need was very high, but only few could get onto the train. And at that time, we did not have test and treat. So the eligibility criteria was you need to have CD4 mouse drop less than 250. So you must really be getting sick. Okay, and then the drugs that were in use at that time, Zidovudin, we still have Zidovudin around. So we had Zidovudin AZT, that's Lamivudin PTC, and then the Virapin. And then the alternate was Stavudin, Lamivudin, and then the Virapin. Now the thing is that these drugs work very well, but the problem we had with these drugs was the side effects. So you can see this one is a patient with Zidovudin. You can see the anemia, you see very pale. And that's the problem we have to deal with. You see this reaction was from the Virapin. So we're seeing a lot of this, and actually over time, some of the patients, especially those who are on Stavudin, if I see somebody on Stavudin 100 meters away, you see that this patient is on Stavudin. So these were problems. And then when you move to second line, you see, you look at the pills that they had to take. In Ghana, we had Nelfinavir. So you can see Nelfinavir alone is 10 pills in addition to the nucleoside backbone that you have. So this was really We made progress, but it was so tough. And then tenofovir came to the rescue. Why did we have to start using tenofovir? Because like I mentioned, the side effect on the zidovudine was a problem. Again, the stavudine was a problem. And then also, we observed that the resistance mutation that we're getting from these drugs, we call them the timidins or thymidines, for those of you who do biochemistry, the thymidine analogs. The mutations we're getting were what we call TAMs, thymidine-associated mutations, and they were multiple. So when you get one, they move to 2, they move to 3. Now, when you start getting more than 3, 4, what happens is that all the drugs in that class will not work. So that in itself was a problem. And then tenofovir came around. Tenofovir, the good thing about tenofovir was that the type of resistance you get in tenofovir was slightly different. That resistance was not the one that was cumulative. You get it one, and then even when you get it, the drug still has some activity. It doesn't knock it off completely. So that came to the rescue, and then you see that the guidelines started changing and we're moving to tenofovir, lamivudine, and efavirenz, and that is how stavudine and others started disappearing. Then we moved to the stage where we got what we call the integrase strand inhibitors, INSTI. The INSTIs, so the first generation integrase strand inhibitors was what we call raltegravir. Raltegravir, we had a few patients who we used for, but now I don't think we have a lot in the system. Now raltegravir half-life was about 7 hours, and generally the raltegravir, in terms of effectiveness, it was a potent drug, but normally when you get resistance, you lose the drug. Okay. Then we had some first generation. That one we never had it in Ghana. The L-vitagravir. L-vitagravir is typically given with another drug we call a booster, cobicistat. So, and these drugs are slowly disappearing. Then we came to the age of the second generation, and we are still in the second generation integrase strand inhibitors. So, dolutegravir, and I think dolutegravir is everywhere now. Dolutegravir, we have it in first line, we have it in second line, we have some patients on third line. And dolutegravir, when it came on board, actually became the most potent ARV that we have seen. I mean, before then it was darunavir, and then dolutegravir came on. And this was a drug where you need to get multiple mutations before you can knock off the drug. So it's a very, very potent drug, very potent. And then the half-life was relatively long. Then there's a very similar drug to dolutegravir, bictegravir. Bictegravir, the structure is similar to dolutegravir, but it was, engineered by the lab by the Gilead folks, and it's similar to dolutegravir. It has a very high genetic barrier. So these drugs, you will need a lot of resistance mutations to knock it off. Okay. Then we have cabotegravir. Now for cabotegravir, what you need to know about this drug is that it's long-acting, and I'll talk a bit more about that. It's long-acting, so you can use it as an oral. You can also use it as an injectable. Okay, and I hope you've heard about nanomedicine, where you try and mill the drug into tiny, so that like it's easy for it to go, and then it's released slowly over time. And that is how most of the long-acting work, and I'll get back to that. Then this is in a different group, rilpivirine. Again, we've got a few patients on this, but it's a new, a second generation after the nevirapine and the efavirenz. So rilpivirine is available as oral and then also as an injectable. It also has a very long half-life. Now let's get into some of the new agents. Islatravir. Islatravir is in a new group. We call them the nucleoside reverse transcriptase translocation inhibitors. It works similar to nevirapine and efavirenz, but it works at the level of the chain termination. So again, very long half-life. You see the half-life, we are talking about 8 to 10 days. Okay, and also very, very potent. And then now it's been explored as an oral and also an implant. Okay, so it's latravir. So now let me switch to long-acting agents. So what's the long-acting agent? Long-acting agent basically is an agent that you can deliver over 24 hours. Okay, so 24 hours, it means it can be once a week or more, and then there are different ways of delivering it. It could be oral, vaginal, intramuscular, subcutaneous, and then there are different possibilities in terms of technology. So we have the injectables. You can have the microneedle drug patch. Currently, we don't have it, but it's a possibility as we move on. Then actually, we are coming up with novel oral formulations that can act long. That is work that's going on. There's also the wearable infusion pumps. Vaginal, we already have it for dapivrin. Okay. So now, when you look at cabotegravir long-acting, I'm not going to go through all these studies, but all these studies tell you that cabotegravir long-acting is extremely effective, and in some instances, it's actually more effective than the drugs that are available orally. And the reason is simple: it's long-acting. You don't have to remember to take your pills. You get a jab and then you are on the move. So now, which agents today are approved for long-acting? So the first one is cabotegravir. So you can give it either monthly or 2 monthly, okay, depending on the dose. And most people will go for 2 monthly. Then we have the rilpivirine. So rilpivirine, again, monthly or 2 monthly. Normally the rilpivirine will go with the cabotegravir. But the problem with the rilpivirine is that you need to keep it in a cold chain. Okay. Then the new kid on the block is lenacapavir. So lenacapavir, you give it subcutaneous, but that is every 6 months for treatment experience. Now, let me say this: because you need more than one drug to treat, even with lenacapavir, the other drugs you have to take it more frequently. Okay, so for now, we don't have any agent where you take it twice a year. It's not possible, not yet. So you may be able to take this one, but the others you may have to take it more often. Okay. Now let's go into the 2-drug regimen, and this is an area that a lot of work has been done. And for me, it's a joy because this is one area of HIV medicine that I never expected to see in my lifetime, because a lot of 2-drug regimens have been tried and they have all failed badly. So now, the traditional teaching for HIV treatment is that you need 3 drugs from 2 classes. And this has been the standard of care for many years, even now. It's still the standard of care. And then, like I said, in the early studies, the 2-drug regimens, most of them, they start well, maybe a year after year, they fail. Okay? But as we treat more and more patients, you realize that there are some special patients that may have problems with toxicity, kidneys, and other organs. And sometimes you really want to drop one drug that is causing it. So people again started looking at these different options of treating with 2 drugs. And there's been a number of studies. So now let's start with treating with 2 drugs when the person has been on treatment before. So the ART experience. Now, it started with you give the traditional drugs and make sure that the patient is fully suppressed. Now, when the patient is fully suppressed, then you move on to the 2-drug regimen. So, and it's been tried and it's worked well in a number of instances. And actually, for WHO doesn't recommend it. But if you look at the European and the US guidelines, it's in their guidelines. But I'm sure eventually WHO will come around. So, what are some of the options? The options include dolutegravir and lamivudine. And these are the studies to support it: Tango, Salsa, Dola. Then we have dolutegravir and rilpivirine. Then we have cabotegravir and rilpivirine. That is the most popular now, and I'll get more into it. And now we have the DTG, that's dolutegravir and darunavir. And like I said, before dolutegravir came about, darunavir was the most potent ARV. So you have these two together, and I'll go more into details. So now let's look at some of these. So when you look at the two-drug regimen, ART experience, dolutegravir and lamivudine for treatment experience. Bottom line is that they followed up these people for more than 5 years. Okay, this is not just 1 year, more than 5 years. And you can see that 77% were still on dolutegravir and lamivudine, no biologic failure. The patients who stopped treatment was not related to the study drug. And then this is a very important study, and to actually influence the noise guideline that will be coming, the global guidelines. That is a dolutegravir and darunavir evaluation in adults failing first-line therapy, so like the tenofovir, lamivudine, and the fibrates. And then when they failed, what they did was originally, when you failed NRTI, you give a PI, protease inhibitor. So first they were randomized to receive darunavir and then the two nucleosides, and then also another group to darunavir and dolutegravir. And then later another arm was added where they did dolutegravir, lamivudine, and emtricitabine, and tenofovir. So you had these three arms. Now what happened? If you look at it, so this was the beginning of the study. So you can see that the darunavir plus the two nucleosides is actually the standard of care. And this is the dolutegravir and the darunavir. You can see the dolutegravir and darunavir outperforms the standard of care. Okay, now if you take all the three groups, again you can see that the dolutegravir and darunavir outperforms darunavir with the two nucleosides, and then also dolutegravir TDF, and then lamivudine or emtricitabine. Okay. So this was very, very strong evidence on these agents. Then also, some work was done on people who just come, initial therapy. And this was in the Gemini 1 and 2 studies. Now, the problem with this study was that they really did not have a lot of patients with viral load more than 500,000 copies per million. Okay, so even though this was found to be effective, the guidelines, like the US guidelines and the European guidelines, state that one, the viral load must be less than 500,000 before you can do that. Number two, you need to do baseline drug resistance, which we cannot do here. So again, that is a limitation. And we have to do baseline drug resistance because you see, dolutegravir is in the same family as what? Cabotegravir, isn't it? And then we in a lot of locations, we are giving cabotegravir as PrEP. Okay, so before you do this, then it means you have to do resistance testing. So this is something that, in terms of public health approach, that may not work well, but it's something that you need to know about. Then the challenges for the two-drug regimen. The first one is resistance testing. Even our current patients are struggling with the resistance testing. Then hepatitis B. You know, hepatitis B is very common in this country, especially when you move from the southern part of the country going up north, it increases. Now, tenofovir treats hepatitis B. If you do a two-drug regimen, that cannot treat hepatitis B. So if you have a co-infection, that becomes a problem. Then, of course, how do you adjust your dose when you have TB as well? And you know, TB is also common in our environment. Then, like I mentioned earlier, ropinirole, you need a cold chain. Okay, and then these things have not been well studied in pregnant women and then in children. Now, let me move to dolutegravir resistance, factor of fear mongering. And a lot of people have been worried because, you know, because dolutegravir is so potent, we are using it across. And there are concerns that if the world loses dolutegravir, what is going to happen? So these are some of the concerns that were expressed. Now, this is a bit technical, but I'll try and explain the best I can. These are resistance mutations. where you see a bold figure, it means it's what we call a major mutation. Okay. Now, like I said, dolutegravir or cabotegravir, you need a high resistance barrier. So normally you need multiple of those mutations. Now, if you look, you can see that dolutegravir has 110, isn't it? 110, 140, and I think 148. Then there's 155 and 263. Now let's look at that is cabotegravir. Sorry, look at dolutegravir. You see, dolutegravir is sharing the same mutation as cabotegravir. They share 118, they share 140, they share 148, and then they share 263. You understand? So straight away, if you are cabotegravir and you start developing mutations and you take dolutegravir, you may have problems, especially if the mutations are many. So this is the reason why if the person has been exposed to dolutegravir, you need to do the resistance testing to check. Otherwise, your drug may not work. Okay. So these are studies that shows dolutegravir resistance mutations. This is coming from Brazil. They did find some major mutations. This is a cohort that was done Canada, France, Netherlands, Germany, Switzerland, South Africa, and 1%. You see, there are different mutations, but the major ones, 1% have high resistance. So it's still not bad because you know the drug is very, very potent. Then there is also again, this is coming from sub-Saharan Africa. And then generally for those who are suppressed, you normally don't see the mutation, but those who are not suppressed, then you may see some of the DTG mutations. And actually they actually saw some of the, you know, when we're transitioning from efavirenz to dolutegravir, some of the patients who are not suppressed, they are seeing some of these mutations, okay? Okay, this gives you an overview of some of the dolutegravir resistance. The only thing is that even though we are seeing it in terms of the major mutations, it's on the low side, but it's something that the alarm has been raised that we really need to be careful. Now let's look at implementing evidence-based guidelines in the process. So now we go to the WHO guideline, that's the public health approach. So you see the public health approach today, you see we give tenofovir, lamivudine, mentholatum, and then dolutegravir. Of course, then your alternate is that, but you give efavirenz. So, and then these are under special circumstances. Now, when you come to the Ghana guideline actually follows the WHO guidelines. You see, tenofovir, lamivudine, or mentholatum, and then dolutegravir. Okay. Now let's go to the US. Now, when you go to the US guidelines, you see the US guideline, we do dolutegravir, lamivudine, or mentholatum, and then tenofovir. The US guideline does bictegravir instead of the dolutegravir. Okay, so they do bictegravir, TAF, and then mentholatum. So that's the preferred. Then they also have what we have. That's the dolutegravir plus TAF or TDF, and then mentholatum. Again, this is also widely used. So it means that now we are not too far behind in terms of treatment. Then the US guidelines also gives provision for 2 drug regimens. You can see dolutegravir and 3TC. But then they said you don't give it to individuals with what more than 500,000 copies per mil in terms of viral load. The person must not have hepatitis B, and then you should have done genotypic resistance before. Okay, so you see, it's there in their guidelines. Then this is the European guidelines. So the European guidelines is basically similar to what you have in the US. So again, they do what we do, and that is tenofovir, lamivudine, mentholatum. Then they also have bictegravir. Then they also have provision for 2 drug regimens. Okay, but again, the conditions are that you must be hepatitis B negative, and then also less than 500,000 copies per mil, and then you should not have been exposed to cabotegravir from PrEP. Looking into the future, so what are the potential combinations? So if you look at the potential combinations, now you can give cabotegravir every 2 months. You can give lenacapavir every 6 months. So one potential combination is cabotegravir, which means the cabotegravir you have to take it 6 times in a year. But cabotegravir typically it comes in a pack, and because of the volume, you have to give them just 1 here and then 1 in the other bottles. Then we go to the next one is islatravir. Now islatravir and lenacapavir. Currently, recently at the meeting that CROI in Denver, there was a presentation on this drug where you give the drug once a week. Okay, so you give it once a week, and the results are really great. So 94% of those who switch from islatravir, lenacapavir, actually maintain undetectable viral load, and it was actually comparable to those who have emphysically and beta-glucan. Okay, so you can see that we are really making progress because now all the long-acting agents are injectables. Okay, so this is what we are pushing towards oral long-acting agents. So and for now, it's the longest oral agent that we have till other studies come. So to conclude, we have made significant improvements in the safety and potency of antiretroviral drugs in the last 20 years. Though uncommon, the dolutegravir resistance can develop. We have seen it, and it's very, very important that we really monitor this. It's critical, and I think where we have gotten into the program, we really need to have those facilities to have to monitor dolutegravir resistance. Now, the long-acting agents, whether we like it or not, because you see, cabotegravir rilpivirine is already there. There are a lot of people on it already in Europe and America. Eventually, it may come here, and it's important that do we have the clinical care and treatment system that we have in the country today? Will we be able to deliver long-acting agents? And I think it's important that we start preparing because it will get here. And I think that is my last slide, and I really need to acknowledge my colleagues, Francois, and then Serge, and then the Ghana Health Service, and then ECP, and then the University of Ghana.
Thank you very much. I hope Kwesi hasn't confused you. The language we speak behind the scenes. But in summary, I mean, I think what he was saying was that those days when our patients used to take 21 tablets a day, to now where, you know, there's opportunity for you to take these tablets that work over a long period. But there's also the opportunity for research. As you know, it's a research dialogue. So we are looking at where we can come in and do research. As a country, we've tried to move away from injectables. So now all our anti-malarials, most of them are oral. If we have to go back to injectables, what about IPC? What about things like injection abscesses? What about resistance and all that? So with all these, as we are listening, remember there are also opportunities for research. We need to do research and also inform the program on what is doable and what is not doable. So thank you very much, Kwesi. I'm sure during question and answer time, you can expound on some of the things. So our next speaker is Professor Dorcas Obriebo. I just call her Dorcas. But Dorcas is a professor of clinical microbiology and infectious disease in the School of Medical Sciences, University of Cape Coast. So she's a clinical scientist. And she works particularly with sexually transmitted infections, HIV being one, HPV, viral hepatitis, etc. I remember in 2013, we were touted as one of the countries that was almost eliminating mother-to-child transmission. We and Senegal and the third country. Now I'm not sure we are in that category. But Dorcas is going to tell us about elimination of mother-to-child, and we can see how we can come in and also work. Shall we welcome her with a round of applause?
Thank you very much, Prof. So hopefully I'm going to be far less technical. So it's one of the things that makes me always happy is one of the first cases that I saw. And this woman had a child that we was able to successfully take through PMTCT in 2006. And the girl is in university now. And every time I see her, I'm really, really excited to see her. Please, the gentleman who did, okay, sorry, fine, it's fine. So I'm going to just try, and I'm supposed to talk about the perspectives and the Ghana's journey towards elimination of mother-to-child transmission. Sometimes I'll say PMTCT, sometimes I'll say EMTCT. It's just my tongue and whatever it chooses at that point. So we want to look at the perspectives, but of course we will look at the Ghana's journey in the context of what is also globally happening and what has happened over the years, how that has shaped and informed what is happening and has happened in Ghana. We all agree that mother-to-child transmission is and has always remained so far as a global problem. But many barriers have existed and a lot of efforts have been made to deal with this. But the reason we keep talking about it and it's still a priority area is because the barriers to eliminating mother-to-child transmission of HIV has been numerous. And we can all sit here and talk about many from our own experiences. And lower and middle income countries like Ghana now bear the biggest brunt of this problem. So once we are looking at what we've been able to do in the past 20 years, we cannot do that without looking at this area of mother-to-child transmission and what we have been able to achieve so far. This is just the usual stories we tell about the pillars. It is not to give anybody any long lecture on what the issues are. But if you are going to have a generation free of HIV, you need to ensure that your systems are in place to attempt to prevent HIV infection in the population as a whole in the first place. And if you still, and you do have women living with HIV, you would want to then ensure that steps are still taken if they choose to get pregnant, that in that pregnancy, efforts are made towards preventing that unborn child from being infected. And when they deliver, these efforts continue. And you would want to remember that this all includes the community. If you are going to be successful in this exercise, you have to engage the various communities that are directly involved in this issue, which include, of course, the men, and I'll touch a little bit more on them later. So WHO, UNAIDS have taken on this task of working with the world towards elimination of mother-to-child transmission for a long period of time. And I want to highlight the fact that all the strategies and things have been informed by the science. We are talking about the science dialogue. So what needs to be done, all the strategies that have come over the years and keep changing over periods. I remember somebody said, WHO can't make its mind up. It keeps saying, do this, and then it changed to do that. It is an issue of what the science proves at what point. That will show you that from the evidence, change to the strategy. So over the years, that is what has been happening, that based on the new scientific advancements, whether in the area of diagnostics or antiretroviral drugs, as we've just heard a lot of big words that you will not be able to pronounce, all of that shape what is decided, and we move along with it. Once the global scientific advancements inform some strategy, we are always, and countries are always encouraged to also adapt, contextualize these strategies so that what you decide to do fits in well in your country, because it has to fit in the socioeconomic, cultural, and all the context, health system factors in your country. But whatever you do, it has been clear for many decades that it requires a comprehensive approach. Preventing or eliminating mother-to-child transmission of HIV is a comprehensive strategy. This is to show you at least one good news over the years, what has happened. So what you see here is showing you from 2020 to 2023 that with the use of antiretroviral medications, you can see that this is where we are in terms of current antiretroviral available to pregnant women and breastfeeding women. And on that basis, as you can see here, 4 million new HIV infections are vetted among children. So this is a lot. If we didn't have all these medications and strategies, this is where we would have been. So we have to applaud and be happy that we have done something. But in the recent times, you can see from this slide that things are getting stagnated, and we need to relook and rethink what is happening. You will see that in terms of percentage of pregnant and breastfeeding women living with HIV that are receiving antiretroviral therapy, the percentage is not increasing. It is stagnated. And this is the global picture. And with that, the annual number of children acquiring HIV, yes, there is some decline, but this is not the slope we want to see. And if you put that same thing in the context of Africa, you see a very similar picture. So I'm going straight to Western and Central Africa because that then includes us. That in terms of proportion of pregnant women that are receiving antiretroviral therapy, you see we are not doing too well, and the slope in terms of HIV infected babies is even getting far less going down. So we really have stagnated for some time, and this from around 2014 thereabout, you see that not much change is happening. This is the reality of the world. But remember, we said that lower and middle income countries like Ghana contribute and have a much bigger burden. With that global context, let me touch and focus on Ghana's situation and my perspectives of what has happened over the years, and therefore what I think we should be looking at or thinking through a bit more. So we know that Ghana has a comprehensive policy, and it has had for these 2 decades that we've been talking about, and I'll show some timelines very soon. So what are some of the strategies or guidelines related issues? Of course, that we have been pushing, the program has kept pushing for integrated programs. And that is what the world wants. The evidence shows that if you integrate this and avoid siloed programs where a woman comes here, this place is just for HIV testing, then the drug, if you would take, is that building across. You cannot keep doing that. He needs to make an announcement, so sorry.
Thank you very much, and sorry for that. Owner of car with registration number GW 114412. Please, you block some team. They are supposed to move to the airport. So please, if you are here, GW 1144 114412, please move out and move your car if you are here. Thank you. Please, that is not part. So if you know you blocked someone, just quickly move out. If you know it didn't park well, yes, please move out, and they need to go to the airport. Thank you.
So we hope people know their car numbers. As he was mentioning, I was trying to remember my car numbers. Anyway, so let's move on again. So we are talking about what Ghana as programs is focused or is shaped around: integrated, decentralized, and of course in that, the evidence-based policy of task shifting has been very helpful, because then it means that right to that community where that woman lives, where that pregnant woman lives, she can receive the services from the healthcare workers or cadre of staff that are there. But that has required a lot of capacity building. So all of us here, and I see many faces that I have seen in training over and over and over again, building capacity of healthcare workers to make sure that they can be in the communities and do this service provision. So I have this journey here, this timeline of Ghana, trying to put some perspective to some of the things. So PMTCT in Ghana, the story goes around 2000, 2004, thereabout, when we used to basically, is the opt-in approach, beg pregnant women to agree for us to test them. So please, as you are here, we can do HIV testing. And if you will please agree, I will please want to test you. Do you please agree? And then we used to get the answer, no. A loud no. So we went through that, but even in that, we still struggled and tried to do our best. And then from the global evidence, scientific evidence and everything, Ghana moved to the opt-out approach where we now routinely offer testing, talk to you about it, and it is only if you say directly that you don't want to be tested before the process stopped. If not, the process went on, and then you got the associated counseling and everything was done. And as this was all happening along the years, the number of PMTCT sites were being increased as more training was done and facilities were enrolled onto this. And somewhere along the line, we started using and have been using from the beginning this nevirapine monotherapy. Do you remember? Single dose nevirapine things. Many people here are nodding. They have forgotten that is what we used to do. And all sorts of things, criteria to determine who should take antiretroviral therapy. So we have to sit down, get the CD4 count of the pregnant woman. If it's less than 350, then you qualify, and then when you deliver, we stop you, back and forth. As I was preparing this timeline, I was just reflecting and remembering some of the funny things that were happening along that line and the challenges. But of course, option B plus then meant that you get lifelong antiretroviral therapy irrespective of the CD4 count or anything. And of course, treat all men, everybody was on treatment. And Ghana has moved along with these scientific evidences over the years. And there are many additions that are not here. We know where we are currently in terms of the treatment and EID and testing this case, so that a woman doesn't have to wait for 18 months, a year and a half before they get to know whether their child is infected. That period of trying to just keep praying and fasting and waiting, now all of that has been shortened. So it's been a journey, and a journey that continues backed by scientific advancement and evidence, and Ghana has not been left behind. In trying to go through that journey, there have been major things that as a country has continued to be addressed to make sure that whatever scientific strategy you put in place would have the right uptake and therefore have the impact you want. So community engagement, if the people out there are not going to agree for their wives when they go to hospital to be tested, you will keep having them telling you that unless I go and ask my husband. But by continuing to engage the community and making sure that we continue to address their concerns, whatever they may be, it helps. And continuous efforts at stigma reduction help, because then people are not too worried that if they turn out to be positive, it is something that the whole world will get to know, and that will be a problem. Male involvement is one of the areas that has evolved over the years. I remember at a point in time when Know Your Status was targeted at going to places where men gather. So we said, go to football matches, go to the fishing shore when they are pulling. Target the men, because if you could get them on board and you help them to appreciate how it links to their wives, you can deal with the whole family as a whole. Culturally appropriate counseling and health education. And it's very important to always adopt strategies with this in mind, contextualizing it in the country's issues. But Ghana has always had to battle and deal with logistics issues. It doesn't matter how and if everybody is ready to test, but there are no test kits. If the pregnant woman came fighting to be tested, but there is no test kits, you will still have an issue. So over these years of 2 decades journey, the country has continued to look at how to manage stock, logistics optimization, getting data in a way that can help to predict consumption and deal with the supply chain so that you always have logistics. And one of the popular trainings had also become this logistics management training, and it has happened across every breadth and length of the country. All of these are critical barriers to address if PMTCT, EMTCT would achieve its goal, because then you have the supplies, you have the people ready and willing, and then you can test them. So what are I have a few slides to just show some of the achievements from the NSCP report 2023. This gives from 2019 to this time, and you will see that in terms of testing, we still have a gap, and that gap over the years, in fact, if you look at the percentages, it's rather unfortunate that it drops, and then it gives us things to think about that need to be addressed. Coverage for HIV positive pregnant women. Of course, you again see that we've gone to 92 before and then come to 91. So yes, over the years, the change hasn't been very drastic, but definitely more room for improving. But at the end of it all, no matter what you do, the important thing we were trying to do is prevent a child from getting infected. So this one is addressing that issue. That as we've been doing all of this, what has the story been like in terms of how many, what is the rate of positivity from those children? So per the policy, at 6 weeks, we have to know, and these are the rates over the years. And then the final rate is that here, what you see is, are these the rates you hope to see? That after going through the process, 12.63 or something percent of our children come out as positive? No. So yes, some progress has been made and we see some drop, but the drop is not to the extent that we want. So that tells us that there are still things to do. So that as for the scientific facts about what to do to prevent a pregnant woman from bringing out a positive child, the science is clear, it has always been, and it is there. But if you don't address the issues, you will not be able to achieve much. So Ghana has done well, but still need to look and keep looking at what is being done. What are the lessons we can learn, the things we can think about? If you are going to do more, you need this collaboration, and it says effective partnership. Particularly in our context, you see how the partnership with government affects logistics a lot. It should not happen that logistics have arrived, but they are not available to use for testing or to give to a pregnant woman because they are stuck somewhere and cannot be cleared. So a lot of activity or action needs to be taken to make sure that all the stakeholders from the government through the international agencies and partners have contributed to this process continue. And as we keep looking at the global strategies, we need to look at our own context, innovative things that can be introduced. So we've tried mentor mothers, we've tried these peer-to-peer support system to ensure that one pregnant woman can support the other and they can go through the process together. These are things we need to look at and still keep thinking through, and I'm waiting to hear what the research priorities are in one of the presentations on today's program moving forward, because we need to keep looking for new approaches that can ensure that as we put together and re-strategize, we have new things to do. Data driven, that is fine. The data has improved over these years, where now we have more and better data across the cascade for PMTCT and all HIV-related services, but there are still gaps, and that needs to continue to be improved. And in our context in Africa, the community engagement is crucial. If stigma doesn't keep going down, and when NAPLAS was talking, they referred to the stigma index and where we are and what still needs to be done. If that doesn't go down, and make sure that people come to the point where they see HIV testing like going to the pharmacy to test for malaria or something, we will still keep having bottlenecks along the way. And this is the, should I call it a new baby? So for now, we've been talking elimination of mother-to-child transmission of HIV, but we should also know that now we want to move away from that siloed approach to talk about the triple elimination. So a mother does not only have the risk of transmitting HIV to their child, they have for hepatitis B, they have for syphilis, and they have for other sexually transmitted infections. But at least the global focus is on these three, because we can really eliminate transmission of this to an unborn child. So, of course, Ghana has taken steps, and I know NACP in recent times, we have a consultant for triple elimination here in this meeting. Yes, it's true. Yes. So, yeah. I know that there was someone introduced as a consultant for that. So it tells you that the world is making sure we put together our efforts in a way that as you test a pregnant woman for HIV, you are testing for hepatitis B, you are testing for syphilis, and any of those that you find, you put in the measures to make sure that that baby is not born with that infection. So we have obstetrician gynecologists here, and I'm looking at some of their faces, and I'm wondering whether they are even aware that this is where we are now. Of course, with HIV, syphilis, Ghana has been doing that for a while now, where we use the test that does both. But now we need to follow along with the consultant and see how Ghana implements fully the triple elimination strategy. So I am basically coming to an end and saying that, yes, Ghana has made some strides with the elimination of mother-to-child transmission. We got close to the point of being declared as having eliminated. Of course, along the line, the bottlenecks have continued, and we keep fighting this battle. So we need to really work towards this with a sustained global commitment. Make sure our approach remains very much integrated, and in fact, better integrated, so that women are not moved around in facilities just to receive care in any of this. We need to empower our communities. This is where NAPLAS and all other groups come on board to deal with the communities and ensure that we further reduce stigma. We create demand for these services. We want the point where women will come to the facility and fight for testing and get angry if you don't test them for HIV. We want to create the demand, and of course, once we sustain our commitment, the political will, the funding, or all other aspects of it, I'm hoping, and my dream is that we will have that generation where we can truly say that as a country, after 20 years and moving forward, we have eliminated mother-to-child transmission of HIV. And I want to acknowledge all these groups and many more not here. Thank you very much.
Thank you very much. Can we have another round of applause? So even as she was speaking, I hope you saw the opportunities for research and then also for the use of data to inform, the strategic decisions that we take. I think that one of the big issues is data in our institutions. And we very reluctantly try to collect the data, but if the data is comprehensive, then it becomes very useful to determine what is going on and what we can do. So it's a short time. I'll have to manage the time. We have a very short time for questions and answers. So I'm going to say that on behalf of everybody in this room, I'm going to thank Professor Tope and Professor Dr. Sobriyewa for an excellent presentation. Let's give them a round of applause. So I will take a few questions. When you stand up, your name and the question must be brief. Please don't thank them. I've thanked them enough. So when you get up, your name and straight to the point, whether it's to Professor Tope or Professor Sobriyewa. I'll take 4 questions from the in-person audience, and then if there are any online, we'll take them. We'll just probably do 1 round. Okay, I saw your hand up first, and then I see one here, one here. Can I get a 4th hand up? Okay, all right, so we can start. Thank you very much. And then please, let's sort out the online questions as well, if I can have them.
Thank you, Prof. Latte. So my question is to Prof. Tope. He mentioned cabotegravir as something that we already have the ring. And I think in our PrEP guidelines, sorry, I should have mentioned my name. My name is Elizabeth Ijare with the clinical care team of the National AIDS Control Program. So he mentioned cabotegravir as already something that it's a ring. And it's now in our guideline as something that we can be using for PrEP when eventually it gets into the country. I'm just wondering if it has the same resistance profile as dolutegravir, and aren't we worried about resistance even before a client, if we're using it as PrEP, aren't we worried about resistance even before a client gets HIV for the dolutegravir, because we know Dolu is our baby. The second question, still to Prof. Tope. As a clinical microbiologist, we are taught that, if you have 2, 3 drugs, resistance is lower than if you have just 1 drug. And right now, because the 3 drugs have been put into 1 and the side effects are relatively less, I'm just wondering, what is the huge benefit of having 2 drugs instead of 3? Thank you.
Thank you.
Thank you so much. My name is Chris Abana from Noguchi. My question is to Prof. Tope. I wanted to find out, throughout his presentation, he didn't make mention of treatment for HIV-2. If there's any tend to talk about that on HIV-2. Thank you.
Thank you very much. My name is Divine Antipra from UNFPA. My question is to Prof. Tope and maybe Prof. Lali. I just want to know, with all the presentation that you've done, the research, areas that you have worked in, where are we now when you look into the horoscope? Where are we now in terms of being able to get a cure for HIV/AIDS? And then also, apart from that, also if there's any information on the vaccination that we actually, because immunization for some time, they've been working on it and want to know where you are now with that. Thank you.
Thank you. Are there any online? Where are they? Okay, so, Prof, are you ready?
Yes. Okay, so HIV-2. I think I'll start with that one. That's very easy. So HIV-2, fortunately, we've made very good progress, because when you look at the beginning, then non-nucleosides couldn't treat HIV-2. We're using the protease inhibitors. So protease inhibitors can treat HIV-2. The integrase inhibitors can treat HIV-2. So I think we are fairly covered there. Then cabotegravir. The cabotegravir is not a ring. It's the dapivirine, which is a ring. So cabotegravir as PrEP, yes, that's correct. But you see, if you look at, remember that if you are giving PrEP, and this also happened for tenofovir, we are always afraid that they will develop, there will be a breakthrough infection and then they develop resistance. But we realize that it's a worry that we don't have to lose sleep over, because the numbers are very, very few. And for that small risk, I don't think it has to stop you from doing the bigger good. So that should not be a major problem. The 2 versus 3 drugs is interesting, but you see, Prof. Latte is here, Ganu is here, there are some patients, and we've seen quite a number of them, especially people who are treatment experienced, where they are on 3 drugs, but the 3rd drug is creating problems. A common example we've had in this country is tenofovir. So if the tenofovir is creating problems for the patient is suppressed and everything, and then you are afraid. And actually this 2-drug regimen is coming out of metabolic abnormalities and toxicity. So it actually has a place in treatment. You see, now it's not something that is like the public health approach you do for everybody. You may have to individualize, and some patients may need that. Okay. Then research, cure has been tough. It's been tough, and but I think in the last 2-3 years, a lot of us are getting hope, because you see, there are a lot of things going on. For example, I'm sure you've heard about the gene therapy. The CRISPR is on. We also have and COVID. COVID has also taught us a lot of things. So now, because all the classical vaccine strategy like the adenoviruses and all those things has failed. So now there is work going on with the mRNA, just using the technology for the COVID vaccines. So some preliminary studies started in the US. Now South Africa, Rwanda are involved in bigger studies. So we are hopeful that some of these things may come good. And then also we have what we call the broadly neutralizing antibodies, the BNAFs. The BNAFs are also around, and so we think that there's a lot of momentum in terms of trying to in the cure area. We've not gotten there yet, but I think we are in a better place than we were 10 years ago. I think I've covered everything. Yes. Thank
you. So thank you very much. Are there any questions from online, please? Yeah, there are none online. Right. Okay, so I'll take 2 more and then we'll wrap up this session. So there's one from the back and then.
Thanks for the opportunity. I think many of the things that we are talking about is drug-resistant testing, at least for people to be able to be bold enough to put patients on 2-drug therapy, 3-drug therapy, and all the other options. So my question broadly goes to the NACP, because most of the things that you're talking about, even the research that we want to do, needs equipped laboratories. So are we going to get drug-resistant testing for HIV in country soon? And if soon, how soon is soon?
Thank you very much. That's a loaded question for Dr. Isiadi. So we'll take the last one. Yes.
Okay, thank you very much. My name is Ernest Otten with the Ghana HIV/AIDS Network. Now, my question goes to Prof. Tope. I want some clarity on lenacapavir. Is he suggesting that even though you take the 2 shots, you still have to be on medication, or if you take the 2 shots, that is it? Thank you very much.
Okay, so I think, like I said, for now we don't have a cure. So whatever you take is for life. So if you are on lenacapavir, you can't give lenacapavir alone because it will be 1 drug. So typically 2 or 3 agents. So if you're on lenacapavir, you have to be on something else in addition to the lenacapavir. It could be 1 or 2 drugs, most likely 2 drugs. So that 2 drug, you have to take it more frequently. And like I explained in my presentation, if you're on cabotegravir, the either one you take it every 2 months. Then the lenacapavir every 6 months for life till there is a cure. So basically that's what. That answer your question.
My understanding is that you go for 1 shot, then 6 months later you go for another shot. So if you have to intermittently take other medications, then what is the point? Why
so no, don't confuse 2 things.
Okay.
I know what you are talking about. He's talking about lenacapavir for PrEP, for prevention.
Okay.
Lenacapavir for prevention, you take it only 1 drug, just like we have PrEP for tenofovir and all those things. So lenacapavir for prevention, that one is fine. But for treatment, you need other agents, 2 or 3 drugs.
But for prevention, one, yes. Yeah.
Thank you.
So maybe what I need to add is based on what Prof said. Now there are studies for only the two medications. Okay, so if we're able to build the evidence that if you do just that without the others. So let's continue to dream, even for the PrEP. We were trying to put in the study to look at acceptability, people's expectation about this long acting. It was not easy because even the molecule to do the study was not, available. WHO couldn't give us the price and all that. And so you hear it in the media that something like that is available, but it's still studied, it's still controlled, and it's very expensive. So my question is, the laboratory, we have started. So Noguchi will tell you, with the support of ASLM and the PEPFAR, trying to build the capacity of some key laboratories in Ghana to be able to do resistance testing. In fact, in the past, we had made the effort to accredit even Noguchi as a ResNet, resistance testing, in Ghana, in the sub-region, but we were not successful due to certain capacity gaps and all that. It's not just simple, but we're still making the effort. As I told you, HIV, antiretroviral therapy, a lot of patients. If Prof. Magelati told you the story of how it was at that time, and today we are celebrating. During those days, if you give a stone to somebody to swallow, the person, and some people even swallow parazone. Some people mix parazone with some antibiotic, give to people living with HIV. Unfortunately, they died. So we've come through a period of frustration, and it's worth celebrating what we are seeing today. Okay. Yeah. The question is not in the country, it's not in the country. We put it somehow in the guidelines, anticipating that maybe we will need it one day, but it's not there. The second question is, how available is self-testing? They are very available now. You can get it from the facility, and if you request to the program, we can give it. Now, Garnett, where is Garnett? Ernest, please wave to them. If I give the mic to him, we will not close. They are doing community distribution of HIV self-testing, and you can contact them. Apart from them, WAPCAS is also distributing to key populations. It's very available. They are not yet. So there's a study now we are undertaking with the School of Public Health and some which university outside to look at Manchester, delivering it through pharmacies. In our guidelines, we put it there already. And we've engaged the Chamber of Pharmacy and other groups to help us do that. So it's not in pharmacy yet, and we hope it will be there. And we are encouraging the manufacturers to do the marketing in the pharmacies. The cure vaccine or the cure treatment is been answered. Let's continue to pray. Everything is possible. Or I should add 24 hours.
So thank you very much, Dr. Isiadro. Professor Bria, you didn't have any questions. I will spare you. So, Professor today. So let's show appreciation with another round of applause. So thank you very much. So at this time, I'm going to call on the program manager, Dr. Isiadro, to tell us a bit about ICASA 2025. I'm sure he will explain what it stands for, what it means, what our commitments are, and what our responsibilities will be. Thank you very much.
Thank you so much, Professor Magelati. I'm going to also tell a story, but before that, let me get into the research mode a little. Because in research is like looking into a microscope. And so you use a lens. So spectacles, but where is it? I'm not finding it. So you put the lens, and then you look intently into something. I'm just using it to be able to determine the people I'm addressing. So I think I've achieved that. I can see the gonococci and everything. So International Conference for AIDS and STI in Africa is ICASA. And ladies and gentlemen, between April the 20th to the 4th October, great things have happened. And it's very similar to the story of introduced antiretroviral therapy 17 years after we identified the first case of HIV in 1986. So, for some reason, on the 20th of April, in response to the call by the Society for AIDS and STI in Africa, who are the organizers of ICASA, this being the 25th year, to hosting this, Ghana submitted a bid. And this has been, I think, the third time, because Ghana has submitted before through the Ghana AIDS Commission. The last effort was in 2016. We were not successful. This conference is a biennial conference that brings together delegates, researchers, activists, and professionals. If you are aware of the International AIDS Society conference, IAS, this is more like the Africa version, and it's big. So far, the last time that this was held was in Zimbabwe, and I had the opportunity to be part of it with a big delegation from Ghana. And I participated in previous sessions and been part of the planning committees. I had met the president or the director of ICASA earlier, I remember, with Dr. Sarko there to discuss ways of organizing this conference potentially in Ghana and all that. All those were dreams at that time. And so at the last conference in Zimbabwe, the ambassador in Trakwa posed an important question when he visited Ghana, the Ghanaian delegation, and asked me why we cannot host the ICASA. I said it's possible, but anytime they come, they say we don't have the facilities and all that. But I tell you, this time around, we're going to do everything possible to host it. So from the momentum of ICASA, and I think that occasion, I missed my flight when I was returning to Ghana, but that has translated in something positive. So in life, when you go through negative things, look at the other side. It will turn into positive. Say amen. Amen. The ICASA the conference brings about, in fact, the last count, 8,118 in-person delegates and 1,571 virtual participants, from 105 countries participated in Zimbabwe. We had various prominent people, the president of Zimbabwe and other people who participated in that conference. So Ghana, the significance of hosting this in Ghana is very huge. It's very, very huge. I mean, it establishes Ghana as a, for political leadership, a haven of peace and stable democracy, to bring all these people. And this time we're expecting more than 10,000 people, based on the feedback I've had so far. It will also create an opportunity for our public health. It establishes us as leader in public health delivery. And it will highlight our progress and innovations in healthcare, building on all that we have done from COVID-19. It will have a great economic impact. The conference is expected to bring more than 10,000. Can you imagine the impact on transportation, food, and all that? The capacity opportunity, the provision of platform to exchange ideas, best practices, and all that is very important. It also serves as a rallying point for advocacy, and awareness. So we were very happy when we submitted the bid 20th April with the support of leadership of Ghana Health Service, Ministry of Health. And Ghana was shortlisted together with South Africa. And by the grace of God, the assessors came. One of the major criteria was to meet the president. And so we wrote to the president. His Excellency graciously hosted the assessors. And on that occasion, it changed the figures. It changed the narrative. And after that assessment, despite the fact that South Africa was looking down on us, because they have a lot of conference facilities and all that. With the little presentation that we made, with the possibility mindset, we were able to prevail. So it was announced formally on the 12th of October at the Jubilee House that Ghana has now been successfully selected as a country to host ICASA 2025. It's going to take place from the 3rd to the 4th to 8th of December next year. So at this stage, we believe that it's a collective effort. I want to thank all our partners, civil society, the academia. When I was going around for endorsement to the bid, it was not easy. Some people discouraged me. They said, but you don't have the capacity. What can you do? But by the grace of God, we have prevailed, and now the work has started. Development partners, civil society, everybody is going to play a role, and we're going to rely on you. But the relevance of this presentation in this meeting context is research. Okay, it's research. There will be abstracts, will receive all kinds of things, and there will be display of Ghanaian culture. All those will be nice. But at the end of the day, there must be documentation. So I invite you within the context of this research dialogue to consider this as a project which we are going to actually go through to come out with a book, a publication. Since this is the first time, we're going to have a deliverable, a hard copy, plus soft and other things, which will be lodged in our newly refurbished e-library and will be available to all stakeholders in the national response. We're going to have a book which will have background to this, the efforts we've made, Ghana's bid, the important milestones. How did we craft the proposal to be able to sell? How did we submit it? What were the issues at that time? I remember trying to overcome barriers at leadership level, trying to get people to sign and all that, would document all that. How I had to beg, we had to beg. And the people who were with me, the supporting documents, communications between the Ghana Health Service Ministry, between Society for AIDS Africa and the presidency. Issues about assessment when we went to International Conference Center, the gaps and all those things. We're going to document all of this very clearly. When the announcement came, there was a media launch, there was a review of the MOU and all that. The media are going to play a role. Their role will be documented. Throughout the period, we are going to ensure that we also indicate the people who contributed to this, and they will be named and listed. We will continue to document till the event itself, and then after the event. So there will be key themes like the role of institutions, leadership, media, academia, sponsors, and all that. We'll highlight the benefits of ICASA, the challenges and anxieties, and all that, and how that will play out for the way forward for the national program as far as our research is concerned, including the launch of the book, because I'm hoping that that book that will be published will be launched, and we'll use it to also raise funds for the research agenda, so that this will give meaning to the fact that this is a national HIV STI research dialogue series. It's not a one-off event. So the lead institution is Ghana Health Service, NACP. Will be supported by the society and the commission. And obviously, there will be the PI is myself and co with other people, supported by some key people who were there at the beginning. There will be contributors. And this will be every stakeholder who is interested will be a contributor, apart from the staff of NACP. We'll have reviewers like I'm sure Professor Kwesi Tope and all the other people who played a role. Editorial oversight will be constituted. There will be a group to look at all that. And then we believe that graphic communication, they've helped us in our advocacy this year. They can be the official publication organization. This project I'm talking about is continuing. It has started already. It's going to end, I think, somewhere 2026. I believe after the conference and the reporting and all that, we should finish that. And we believe that the funding from this should come from at the end of our dialogue and ARTR 20, some resources that have come in, and also new funding from our partners. I'm saying this because our partners are here, and I'm inviting all of us to be interested in this. After ARTR 20, next year, preparation towards ICASA 2025 is our headline advocacy activity. If we don't continue to let HIV message be in the public domain, people have already concerned into the background. So everything we are doing must be reinforced. So ICASA, the country will be colored ICASA 2025 next year, and we welcome everybody to be on board and to support, to be able to fund different aspects of it, so that we maintain the momentum from today. We will set an agenda today. All the issues that we need in research will also play out. I want to take the opportunity to invite all of us, those who submitted abstracts, people who are doing research, to begin to prepare their publications, because there will be calls for submission of abstracts and all that. And Ghana must be represented. A lot of the abstracts must come from Ghana because we are hosting. And we want to make this a very memorable occasion. It's the first time, and we believe that it must be the best so far. The society is hosted in Ghana, but this is the first time. And we need to demonstrate to the rest of the world that after this first occasion, it should come again and over and over, so that we benefit from ICASA 2025. So, ladies and gentlemen, the good news is that we are hosting ICASA. You are all invited at this juncture to contribute anytime you see any notice. And let's make this a very successful and memorable occasion next year. Thank you very much.
Thank you very much. Let's put our hands together. And let's clap for ourselves as a country. It is doable. We are going to host ICASA 2025. We all need to be on board. Thank you so much. So on behalf of the chair, our moderator, Prof, thank you so much for moderating this session for us and bringing it to a successful close. Well, we'll move on to the other moderator for the next session. Our next moderator is a senior resident of community health at the Department of Community Health, University of Ghana Medical School, and an antimicrobial resistant fellow of the Fleming Fund. Distinguished ladies and gentlemen, our moderator is Dr. Samuel Pai. With a round of applause, please help me welcome.
Okay, all right, thank you. It's a very good opportunity that we are all, here today to, listen to presentations based on research, because if we have to take decisions as a country, then it largely has to be based on scientific hardcore evidence. And for we, the younger generations that are coming up, this is an opportunity for us. I think so much has to do before. Yes.
They've changed what is on the agenda, I'll be told. So we'll come back to you. You'll be the moderator for the next session. So let me introduce our moderator for this session. Our moderator is a senior research fellow with the Noguchi Memorial Institute for Medical Research, with several publications in the field of HIV. She started work on HIV research since 2000. She's one of the pioneers in monitoring patients on ART from the pilot site in Mena Krobo. Distinguished ladies and gentlemen, I present to you our moderator for this session, Dr. Evelyn Yaya Boni. Please help me welcome her.
Thank you very much.
Good afternoon, everyone. We'll be having 5 presentations in this session. I'll check if I'm supposed to do 3 and maybe the other 2 after the break. So we have our first presenter. It's Dr. Emanuela Ayimbisa Amankwa. Is an internal medicine resident at Kolebu Teaching Hospital for special interest in HIV and its related health challenges. With a Master of Public Health degree, she hopes to combine clinical skills and public health background to support the care and management of people living with HIV. Dr. Amankwa is committed to advancing research in HIV management and is passionate about working towards more comprehensive and accessible healthcare solutions for this population. She'll be speaking to us on high prevalence of cardiovascular diseases among people living with HIV on antiretroviral therapy in a tertiary hospital in Ghana. Please let's welcome Dr. Emanuela.
Good afternoon, everyone. I'm Emanuela Amankwa, and I'll be presenting today on the high prevalence of cardiovascular disease among people living with HIV. And these are my co-authors and then our affiliations. So over the decades, as we've already heard, realized that the ART coverage has increased. In 2010, it was just about 31%, and by 2021, it had increased to 73%. In Ghana, this figure too has increased. In 2000, the figure was 0%. By 2020, it had increased to 60%. This has impacted significantly on the lives of our population living with HIV. They are living longer, the life expectancy is also increasing. Hence, they are at risk for many age-related, chronic, non-age-related comorbidities. Some of them are renal diseases, liver diseases, and cardiovascular diseases. As we already know, cardiovascular diseases are part of the leading cause of mortality and morbidity amongst the general population worldwide. And this has also been found amongst the HIV population. So the prevalence of cardiovascular disease and the risk factors have also been found to be increasing amongst the HIV population. The risk factors for these cardiovascular diseases amongst this population include the traditional risk factors, which we already know: diabetes, dyslipidemia, tobacco smoking, and also the HIV-related ones like low CD4 counts, high viral load, and some specific ART medications. This study was done because we realized that there have been some studies that have been conducted among the people living with HIV on risk factors for cardiovascular disease. But then the specific cardiovascular diseases, we hadn't really seen much studies on these. So this study, that was the aim of this study, to find the pattern of cardiovascular disease among people living with HIV at the Kolebu Teaching Hospital. So this was a retrospective study. It was done at the HIV clinic of the Kolebu Teaching Hospital in 2021. We looked at the charts of 3,905 active HIV clients at the clinic. And then we did a chart review where we took relevant information on their socio-demographic information, their behavioral HIV characteristics, and also the comorbidities that were affecting this population. The data was analyzed using Stata 16, and some descriptive analysis was done. Chi-square test was used to test the association between independent variables, and the dependent variable here was cardiovascular disease. Logistic regression was also done to measure the strength of the association. So some of the independent variables that we looked at included the age, sex, ART type, comorbidities like diabetes, dyslipidemia, hepatitis B, hepatitis C infection, chronic liver disease, and the like. So after review of these charts, we saw that more than 2/3 of them were female, 55% of them were in the 40 to 59%, 40 to 59 year age group, with a mean age of 45.5, plus or minus 12.2 years. More than 80% of them had HIV type 1, and almost 10% had dual infection with HIV type 1 and 2. All the clients were on ARTs, but about 77% of them were on NNRTI, that's the non-nucleoside reverse transcriptase inhibitors. So from this chart, you realize that almost a third of our patients had cardiovascular disease. And reviewing the charts, 6% of them had already documented cardiovascular disease, but then about 3/4 of them developed it whilst on ARTs. This graph here shows the duration on ART and then the development of cardiovascular disease. We see that majority of them developed the cardiovascular disease during or within 5 years of initiation of ARTs. But I must say that when we did our analysis, we did not find any significant association between any particular ART and the development of cardiovascular disease. This could have been as a result of the fact that you are diagnosed with HIV, you come for routine care, hence we are monitoring you and screening for other health conditions. So these could have just been picked up by that fact alone, and not because a specific ART was causing cardiovascular disease. This graph here also shows the various comorbidities and co-infections that the population had. We can see here that, again, cardiovascular disease represented the largest. 1,088 of them had cardiovascular disease, followed by tuberculosis, diabetes, and then the like. The cardiovascular diseases that were documented amongst this population included hypertension, which was the leading, with 26.1, stroke, DVT, heart failure, valvular heart disease, and hypertensive heart disease. The other cardiovascular diseases, apart from hypertension, we noticed that they also had very small prevalence. The prevalence was less than 1%. Again, we thought that this could be because with hypertension, you don't really have to pay to get tested. We just use a SFIG to measure your BPs, and we document it. But with these other ones, patients would have to be investigated, and they would have to pay out of the pockets. So as and when patients, even though you may suspect any of these cardiovascular diseases, we would have to test to ensure that they are really there. And if our patients cannot pay for them, we cannot really diagnose them. Other comorbidities, as I mentioned earlier, tuberculosis made 8.3%, diabetes was 5.5%, and the rest. So factors associated with cardiovascular disease among the population that we studied, we noticed that increasing age was associated with this, just like the general population. Those who were aged 40 to 59 years had a 4-fold increased risk of cardiovascular disease, and those who were even 60 to and above had a 14-fold increase. Diabetes and dyslipidemia increased the odds by more than 2%, by more than 2 times, as compared to those who didn't have diabetes or dyslipidemia. And those with chronic kidney disease were 85% more likely to develop cardiovascular disease from analysis. So in conclusion, what I just showed tells us that we have a high burden of cardiovascular disease among people living with HIV. We must routinely check for these risk factors and the cardiovascular disease amongst them. And then this helps us to give our patients a more comprehensive care. Hopefully this study would help pioneer more studies for us to look at more risk factors that affect people living with HIV, and then to find out what the outcomes of these cardiovascular diseases are. I would like to acknowledge the Fogarty International Center for funding this study, and clients and staff of the HIV clinic of the Kulebu Teaching Hospital. I'd like to say a big thank you to my co-authors. Thank you.
Thank you, Dr. Amankwa. Please, if you have questions for her, kindly note them down. We'll take them at the end of the 3 presentations. Our next presenter is Dr. Vincent Gano. Dr. Vincent Gano is a medical officer at the Infectious Diseases Center at Kulebu Teaching Hospital. Has been involved in the management of persons living with HIV at both in and outpatient levels of care for the past 8 years. He has also been involved in quite a number of HIV-related research activities and continues to contribute to the fight against HIV through research and capacity building. He will be speaking to us on glucose intolerance among persons living with HIV on DTG-based antiretroviral regimen, outcomes from a longitudinal cohort study in Ghana. Please let's welcome Dr.
Thank you very much. Thank you and good afternoon to all. So my name is Vincent Ganu, and I present to us a study we've conducted on glucose intolerance among people living with HIV on dolutegravir therapy. And these are my co-authors. Yes, so this is the outline of my presentation for today. We'll look at the introduction, we'll look at the methods, then we'll look at the results, the study limitations, the conclusions. Then we'll look at recommendations and then acknowledgements. Okay, so I think since morning we've heard a lot about dolutegravir. So it's been the new kid on the block, and in 2018, WHO had recommended that all HIV programs start using dolutegravir. In 2019, Ghana decided to also roll out dolutegravir. Dolutegravir, I think Prof. Tope has said enough about dolutegravir. In comparison to the other drugs, dolutegravir is less toxic and then has a shorter time to viral suppression. In fact, some studies say 6 weeks, some say 12 weeks. And then also has a high genetic barrier, and therefore resistance to it is very low. And so Ghana decided to roll it out, but then it's happened before in Ghana where antiretroviral therapy was introduced. And then we realized that our patients, when they take the antiretroviral therapy, they could walk for days and not sleep. And then some people decided that they wanted to conduct a study to find out what was happening. And I'm happy that they are still sitting amongst us here. Some are not here. I think Prof. Latte is here. Prof. Kenu is not here. Prof. Tope is here. Together with the National AIDS Control Program, they did a study and found out that the efavirenz drug that we're using, initially it was recommended 800 milligrams. And when the study was done, it was found that the dosage was too high for us, for our people. But then when it was reduced to 600 or 400 milligrams, then our patients were fine. And therefore, this was due to our metabolism. And therefore, this study was picked up by WHO, and it's part of the recommendation, and it's also one of the reasons why we have our efavirenz now being 600 milligrams. So since then, things change. Anytime Ghana wants to introduce something, the country wants to find out, are we different? Or is there something that we need to learn amongst our people? So with this study, when the dolutegravir was rolled out in 2018, we had cross-sectional studies coming out to say there's an association between the drug and people developing diabetes, or some use the word hyperglycemia, that's the sugar levels are going too high. Now, again, there was a systematic review which said that there was no association between dolutegravir and having high sugars. In that systematic review, there were 16 countries. Of them, only 3 were African countries. So if they pull everything together, they tell you there was no significant association. However, when they zoom down to the 3 African countries, then they realize that, okay, there is some association over here. However, I think 2 of the countries, Cameroon and South Africa, it was a randomized control trial. For Cameroon, for Uganda, it was a case control. So we decided that we would do a longitudinal study. We are going to follow people up, but we are going to make sure you do not have problems with your sugar before you are put on dolutegravir. And then we follow you up for some time and find out what happens to your sugar. And that was the reason for this study. So this is a sub-study. The bigger study looked at various things. Looked at hypertension. I think it's part of the posters that we saw over there. We looked at metabolic syndrome, a whole lot of things. And this I'm presenting is just on the sugar. And it was conducted in 4 regions, but in 5 high caseload facilities. And this was conducted in September 2020 to August 2022. So each patient after recruitment was followed up for 1.5 years to see what happens after that. So these are the sites that were used. Now, how did we recruit our patients? So when the patients come to clinic, remember that it's not feasible to call patients to tell them that when you're coming to clinic, you'll be involved in a study. But when you're coming to clinic, most of our patients who come to our clinic come at dawn. They come very early because they want to quickly come and pick up drugs and then they go home. So majority of them actually don't eat before they come. So then for this particular study, it was a good time to take your fasting, to know what their fasting was. For those that do not have eaten, then we have to schedule them and then for them to come. You were screened, your folders were screened, you were asked questions to make sure that you were non-diabetic and that your sugar levels were less than 5.6 millimole per liter. And we were using the WHO definition for normal sugar levels. And then if all these things, you met all these criteria, you were recruited. Now, for recruitment, we had to do a staggered approach to recruitment. So we started first before the other sites. And this was just to learn how the implementation was going, what are the challenges, and then to use those challenges as lessons in implementing in the other sites. So within 6 months, we had recruited our patients, and each participant was followed up for 18 months. So when you are recruited, we had a questionnaire. We take your history, your HIV history, ART history, and then one of the key things we also did was to ask for your last menstrual period because we wanted to be sure that you are not pregnant. Again, pregnancy has a whole different thing that go on, that changes that goes on in them, which affects sugar levels. Now, we did other measurements as well, the BMI, your waist and hip circumference, your blood pressure checks, and then we also conducted some labs, checking your cholesterol levels and then your kidney. Then we did our fasting blood sugar. Now, the fasting blood sugar, we used the glucometer. That's what we use. And actually, it is the approach is what is used as a point of care test at many facilities. And it's quicker, you get your results, and then you're able to make an informed decision. Then our data collection times. So if you were recruited and we get all this information from you, we document your fasting blood sugar down. Please remember that it was an observational cohort study. We're not intervening. Anytime you come, we do the same things for you. So this was done at month 0, which was the baseline. Then we do at months 3, 6, 12, and 18 months. Now, we follow you up. If for any reason you cannot continue the study, you are taken out. However, the number of months or years that you've contributed to the study, it was noted. And that's because we'll use it in calculating our incidence rates. Now, we follow you till a censoring event occurs. So censoring, that's if you've discontinued your dolutegravir, because we are looking for the effect of dolutegravir. So if you stop the dolutegravir, you come back to the clinic. You are no longer allowed to be part of the study. And then if you were lost to follow up, if you got pregnant or you died, or for those who ended the study, it was labeled as a censoring event. Now, we were looking at your sugar levels going above the normal, which we call glucose intolerance. And this was defined as fasting blood glucose levels greater than 5.6 millimole per liter. Now, the person time is what I talked about. People were followed up, and then the incidence rates were calculated. And then we calculated the Cox proportional hazard models for the hazard ratios. Okay, so for our results. So we screened a total of 3,682 patients. Now, 21 of them were pregnant. We had to tell them they were pregnant. And so they were excluded from the study. Then, sorry. Sorry. Please, can you? So we took out the 21 patients who were pregnant. Then after you were taken out, the numbers that were left, for those numbers, what we had to do is to also do the sugar test for them. If we did the sugar test, so these are people who did not know they have, if you have diabetes, you're out of the study. If If you have diabetes, you're out of the study. If you didn't have diabetes, we still check your sugar levels. If we check your sugar levels and your sugar levels, thank you, and your sugar levels were, yes, so your sugar levels were more than 5.6, then we excluded you. And so that's the number. We excluded a total of 2,327 people. 1,740 of them were not diabetics, but their sugar levels were abnormal. And 587 were diabetics. So we had 1,334 who had sugar levels less than 5. Now, 78% of them were female and 64% were aged 25 to 49. And 83% of them were actually on ART before we introduced them to DTG. And 12.5% of them had a comorbidity. So the overall incidence rate was 101.7 per 1,000 person months, meaning if you are following 1,000 of them who are taking dolutegravir in a month, you have 101.7 of them having their sugar levels abnormal. And the incidence proportion of type 2 diabetes, that's those who had frank diabetes, at the end of the day was 11.8%. Now, males, the incidence rate in males was 137, which was higher than that for females, which is 93.9. And again, in the general population, when it comes to diabetics, we have males having more predisposed, more likely to be diagnosed than females. The only difference is that females are diagnosed earlier because they seek help earlier. And then for age, those who were in the 50 to 59 age band had a higher incidence rate of 114 compared to those 18 to 24. Now, for those who were not on ARTs at all before we started them on DTG, the incidence rate was 107, and that's for those who were on ART was 101. So males had 1.3 times the risk of developing glucose intolerance compared to females. Then having a comorbid condition was also associated with 1.2 times the risk of developing glucose intolerance. Now, we had some study limitations. Now, because we're talking to patients and we're getting response from them, there could have been a reporting bias. But then we had to cross-reference information from their records just to reduce the risk of bias. Again, dietary and lifestyle characteristics can also influence your outcome, and which was not covered in this study. Again, this is a research dialogue, so this is something that we can also look at, following such patients up for a very long time. Now, the fasting blood glucose level per the WHO recommendation, and we use the plasma glucose. That's the standard, and the one we take to the lab for them to give us. But we used the glucometers. But we try to reduce that by using the same brand of glucometers. If studies have been done that showed that if you use the same brand of glucometers, you have a 97% high sensitivity of picking up those who are diabetics. Then we did not do HbA1c for those who had glucose intolerance, also as part of the study, which again is also another area that we can look at going forward since this is a research dialogue. In conclusion, we are saying that 1 out of 10, or you follow 100 people out of every 1,000 every month would have their sugar levels being deranged when they are on dolutegravir. And being male and having a comorbidity was associated with a high risk. So we ask that service providers should please ensure screening of sugar levels before DTG initiation. And when they are put on DTG, they should be monitored closely so that once the sugar levels begin to change, we can start looking at the non-pharmacological management. And then researchers should conduct further studies to investigate and conclude on the role of DTG in glucose metabolism. Thank you very much. These are my acknowledgements. Thanks.
Thank you very much, Dr. Ganu. Again, let's note the questions down. We'll ask when the session is over. Our last presentation in this session will be on HIV cure research, presented by Christopher Zabien Abana. He's a postdoctoral fellow on the HIV cure research team in the Virology Department of Noguchi Memorial Institute for Medical Research. He has been in HIV research for more than a decade and contributed to many studies on both HIV-1 and HIV-2. He is an HIV Cure Research Academy Fellow, a member of the American Society of Virology, American Society of Microbiology, the member of the Convention on Biomedical Research in Ghana. During his PhD research, he evaluated epigenetic modifying compounds in African herbs for their ability to reactivate latent HIV. And that is the result he wants to share with us today. Let's welcome Christopher Samuel Abraham.
Okay, thank you so much. My name is Chris Abana, and the title of my presentation is Novel Epigenetic Compounds. Sorry, I can't see. Okay, all right. Thank you. So the title of my presentation is Brain novel epigenetic modifying compounds identified as latency reversing agents, and it's all geared towards finding a cure for HIV. So HIV was detected in 1981, please can you 1981, and far away in the United States of America by Edith. It was identified as a pathogen that infects T helper cells, and as a member of the lentivirus family, and the genome consists of two single-stranded RNA viruses. And like I'm talking to you now, we don't have a cure for HIV. Currently, these are the statistics. Right now, we have about 39 million people living with the virus in the world. And if you go forward, you see that most of these people, the 39 million people, we have over 70% of them being in Africa. That's about 25.6 million people. You can see the distribution of the HIV prevalence in the world. So Africa is leading this. If you come to Ghana, the prevalence here is less than 2%, and most of them are females. And if you can remember, on the front page, one day we woke up in 2020, and we had this at the front page of our daily saying that over 23,000 people have tested positive for HIV. That was during the COVID time. And this tells us, or this informs us that around that time, almost everybody was talking about COVID, and the information or the focus was on COVID and living that of HIV. And because that HIV is still a pandemic in our country. So ART is important, which is antiretroviral therapy is very important, but it doesn't eliminate the virus. And because if someone has HIV and we start treatment, you see that after some time the viral load begins to reduce. And the norm is that when you stop treatment, there is viral rebound, or the virus comes back. And this presupposes that it means that you are supposed to be on ART for the rest of your life. Okay? And even though ART is important, it means that you are supposed to carry it all the time. Okay? Sorry. But however, there are side effects of this antiretroviral therapy. One of them is being the side effects such as being toxic, economic burden, life expectancy, and even access. Access to the drugs is not always available. Sometimes we heard Prof talking about out of stock sometimes. So even though ART is important, we also can talk about drug resistance, mutations developing. So we need to be thinking of other ways that we can combat HIV, even though we know that antiretroviral therapy is important. So how does, usually when someone has HIV, the virus begins to attack the CD4 T cells. When some of the CD4 T cells are infected, some of them will die due to the virus cytopathic effect. There will be some that will remain. Those that remain will kind of proliferate due to the homeostasis. And this will build up and form, this will build up most of these latent viruses, or the one that have HIV, the CD4 T cells will begin to hide, or they are hiding. And this is the major barrier for finding a cure for HIV, because even though the virus is proliferating, we have some that goes into latency. And when it does that, what happens is that when we are treating the patient, all these highly viral latent viruses will be ignored. And at the end of the day, now we must note that these latent viruses are replication competent. They can one day, when they receive the right stimulation, they can one day start replicating HIV. And our goal for treating will be it's not achieved. So this is the major barrier, one of the major barriers for finding a cure for HIV. So to target this latent reservoir, there have been various or different research ideas that have been proposed throughout the world, and some of them include. We can talk about the shock and kill, and this shock and kill, what it does is that it's the whole idea is that while patients on antiretroviral therapy will find an agent that can go and look for the hiding viruses, that can go and wake up those sleeping viruses. So when you wake them up, you can kill them. The killing effect is done either by your immune system, because the immune system will see it as a foreign pathogen, and then they will clear it. Or when it is replicating, the CD4 T cells can also die. So that's the shock and kill approach. That approach just tells us that the person has to be on antiretroviral therapy. So it's a double approach. Now the second approach is what we call the block and lock. Now what this happens is that you're looking for agents that we term latency-inducing agents. And the whole idea is that this agent will go and they are engineers that they go and block or lock permanently those latent viruses, so that even when they replicate, they don't even come out. And then we also had talking about CRISPR-Cas9 earlier on. It's also another molecular method. And the whole idea is that we find tools to deliver this CRISPR-Cas9 that will go into the system of people who have HIV, and then it will clip off where the virus is, and then the person will be free. Another method is using therapeutic vaccine. This whole idea is to boost the immune system so that the person having HIV can fight the virus. So for my research, I use a shock and kill approach. The shock and kill approach explains to us that you're looking for agents that can go and wake these latent viruses up so they can be killed. So the whole idea is that we have sleeping viruses who make noise to wake them up so that we can kill them. The analogy is that if you go to war, if you're a soldier, you go to war, you're not going to kill those who are asleep. You always attack those active ones first. When you're successful in killing those ones, they come to those ones that are asleep. You have to wake them up to kill them. Okay. So why do we even need a cure? It's important. We need a cure because the virus will be eradicated or eliminated. When the virus is eliminated, we are all free. The quality of people of life who live with HIV will also be improved. Most importantly, there will be peace of mind. Everybody wants peace of mind. When you have peace of mind, the world is a happy place for you. Then there will be no stigmatization. People who have a stigma, people who have HIV, not people who have HIV, they have stigma. Everything there's stigma, it's always an issue. Then we're all thinking about our pockets. Those who have HIV, they don't even have some of the money to buy the drug. So if there's no HIV, people's money will be saved. They will save most of their money in the bank, and they can use to divert those money to other things. So we hypothesize that epigenetic modifying compounds will be more effective reactivation agents. And the whole idea is that objective was that we wanted to screen, or we proposed to screen 150 of these epigenetic modifying compounds for the ability to wake HIV up from latency and then to evaluate these compounds in CD4 T cells of people who have HIV. The goal is to bring it to patients. So if we finish doing that in vitro, we need to come to in vivo. Okay. So the approach was that we screen the compounds. We use engineered cells that mimic latency, HIV latency. So these cells have been engineered to have HIV in them, but this HIV is latent. Okay. So we screen those compounds in this latent cell. And then when we find a positive hit, we go ahead to do other screening for For this method, we are looking at screening in primary CD4 T cells and then evaluating the compounds in patients who have HIV. So the approach is that the virus that has been engineered into the cell line, GLAT 10.6 cell line, says that the viral envelope has been knocked off. The viral envelope contains the glycoproteins that are needed to initiate HIV infection. So if that envelope is knocked off, it will be difficult for the virus to initiate or to cause an infection. And the negative factor is also deleted. And in place of that, we have a green fluorescent protein. So that's the reporter to show that if there is an HIV infection, then we will see that green fluorescent protein will be expressed. So the cells were here. We cultured the cells in the 96 wall plate, about 30,000 cells, and then we did flow cytometry to determine the amount of GFP positive cells that have been reactivated. At the end of the screening of 150 compounds, we found 15. 15 of them in such a way that 10 were already known. That shows that our pipeline for screening was effective because we were able to identify already known hits that are effective against HIV. On my left are the new ones, 5 that were new from our study. And we found actinostat MC1568, EPZ 201566, and then they target different components of latency, HDAX, PIM, instrumental transferase. So on my left are the showing us the positive hits that we identified from the screening. On my right is showing us, giving us the graphical view of the results or the data from the flow cytometry. So this shows us the cytotoxicity that was done before the screening. However, we went further to screen the positive hits in different latency cell models, just to be sure that what we are getting is right. Then we went ahead to screen the compounds in macrophages. These are other kind of cells that HIV can also attack. HIV infects CD4 T cells, and they also infect macrophages. So we wanted to check whether HIV, this compound that we have, can also reactivate HIV from these other cells called macrophages. So we saw that the compounds were able to reactivate HIV from latency in these macrophage cell lines. Then we went ahead to collect patient sample for patients who have HIV, and these HIV people we made sure that their viral load was very suppressed, less than 50 copies, so that we treated this. We isolated their CD4 T cells, and then we treated their cells, which contains HIV, with our compound. And we could see a very beautiful HIV mRNA that was identified from their CD4 T cells from all the 4 patients. Okay, these are the 3 compounds that we found. We see that these are the positive control. So these are the 4 patients that we found. We use as a proxy to screen them on our using our identified compounds. So in conclusion, we have identified 3 new latency reversing agents that can reactivate HIV from latency. Our findings suggest that these agents, the whole point for reactivation, and can be used for in people living with HIV as well. And future studies, which is still ongoing, is to really come out to screen these compounds in humanized mice models to be sure that what we have is a good agent for against HIV latency. I would like to acknowledge all these partners that helped us in doing this work. Thank you so much.
Thank you very much. So we have a few minutes for questions from cardiovascular diseases to DTG and diabetes, and then now HIV cure efforts. Any questions from the house, please? Anything that needs clarification? Yes, please.
Thank you very much. I just wanted to ask Dr. Emanuela, I know you did a retrospective study and you were looking at folders, but I also wanted to find out if you checked the history. It should be in the folder if you check the history, whether there was a correlation between a past medical family history of hypertension.
Please, any other questions before they start answering? Yes, there's a question here, please. Yes. Please keep your hands up till the mic gets to you so that you can easily find you.
Hi, my name is Josie Fofana. I'm a Fogarty postdoctoral fellow, and my question is to the last speaker. I know that most LRA's clinical trials have failed for various reasons. Among them, like the compounds that have been tested, were there any epigenetic compounds? And if so, how different are your compounds from the one that have been tested, and do they address the shortcomings of the trials?
Any other? Yes, please.
A quick one. The gentleman who did the work on the diabetes, I wanted to know, apart from you checking the weight and other, whether the person is diabetic, other confounders, you did not give much, or did not give my information. I wanted to know whether you work along those lines also. I mean, do you check on the family history of the persons that you actually work with, and then other conditions that we know that can lead to diabetes? Some of them are medications that we know can, predispose them to diabetes. Did you work on those ones? Thank you.
Thank you for your questions. So one for Dr. Mankwa, one for Dr. Ganu, one for Chris. I hope you all heard your questions, so please just address them for us. Thank you.
So thank you very much. In our work, we didn't look at family history. We're just reviewing what was in the folder. And looking at the folder, there wasn't a slot for family history. And when you look at the HIV booklet, and that's what usually the people with HIV use at the clinic. Unless there was something that was going on with the patient where comprehensive history is written in the book, but we didn't look at family history.
Mr. Dr. Ganu, yes, please.
Thank you very much. I think we captured all this information when we were taking the data from our patients, and we accounted for all of that in the analysis. Thank you.
Thank you. Last one for Chris. You can use it.
Yes, thank you for your question. So the question was based on epigenetic modifying compounds or epigenetic compounds not being promising enough, right? So, what's the importance of our work? Is that not the case? That was the question, right? Yes.
It's different. They've been tried. Some of them have failed. So yours that you have found, how are they different from the ones that have failed? That was the question.
Yes. So, of course, research has that most of them that have been tried have not been promising enough, which I agree to it. However, these are new. When we look through the database, these are in the research as well. These are novel. These are new ones that we found from our study. So, we'd like to go further to look more into it. So, before we can conclude or we can say that this is the case or this is not the case. So, even though I acknowledge that most of them have not been successful or promising enough, in our study we found something different. Yeah. So that's research. So we can't conclude. Right.
Thank you all. We'll bring this session to a close and then we'll move on to, let's thank all our presenters and all of you. Thank you.
Let's clap for our moderator for this session. Thank you very much. You are partially discharged. You come back again. Thank you so much. So, Dr. Samuel Pan, you've already been introduced, so please come and take over for this session. He's our moderator for the next session. Let's welcome him with a round of applause.
Okay, so, all right. So for this session, we'll take the first presentation from, it will be on advanced HIV disease and high mortality rate among HIV positive patients at a tertiary facility in Ghana, post-treat-all recommendation. And this will be taken by Dr. Oladile Oluwakemi. She's a medical doctor with a special focus on mental health and infectious disease on a personal and community level. She has an interest in HIV and mental health comorbidities and the existence of these conditions in adolescents and young adults. She is currently pursuing specialty training in mental health and is interested in the development and implementation of public health policies. She is competent and dedicated individual with about 7 years of experience in medical profession. Ladies and gentlemen, with a round of applause, let's welcome Dr. Oladile Oluwakemi.
Good afternoon, everybody. So, as been introduced, I'm Oladile Oluwakemi, and our study today, our study looked at advanced HIV disease and high mortality rates among HIV positive patients in a tertiary facility in Ghana, post the treat-all recommendation. These are my co-authors and these are our affiliations. Ever since the advent of antiretroviral therapy, which was introduced, or highly active antiretroviral therapy was introduced in 1996 globally, and in Ghana in 2003, it's been observed that there's been a significant reduction in new HIV infections, as well as increased survival rates amongst people living with HIV. And in 2015, the WHO recommended the treat-all policy, which stated that every person living with HIV should be initiated on ART therapy. Prior to this, what obtained was that people with CD4 counts less than 350 cells per milliliter cube, or people who were diagnosed with WHO clinical stage in 3 or 4 were the ones initiated on ARTs. So Ghana therefore incorporated these recommendations into their guidelines in 2016. And we noticed that in most countries, Ghana inclusive, HIV programming was designed to address HIV disease as well as mortality. Therefore, this study was born, and this study sought to evaluate the patterns of advanced HIV disease amongst persons living with HIV and AIDS, admitted at a tertiary hospital in Accra, Ghana, following the implementation of the treat-all policy. The study was a single-center facility-based study carried out at the Infectious Disease Center of the Kolebu Teaching Hospital in Accra, Ghana. It involved the review of clinical records over a 4-year period, starting from January 2016 all the way to December 2019. However, the study was carried out in 2020. The study population involved all patients, HIV positive patients, accessing inpatient services within the period under review. So every person admitted with HIV and AIDS from January 2016 to December 2019 qualified for our study. So in our study, we utilized a standardized questionnaire to collect our information. We focused on socio-demographic data as well as clinical data. Our socio-demographic data included the age of the individual, their sex, their marital status, their educational levels. And our clinical data, we looked primarily at our final advanced HIV diagnosis as well as our survival outcomes. I would like to take us back because I realized I did not explain what advanced HIV disease is. Sorry about that. So advanced HIV disease refers to persons with CD4 cell count less than 200 cells per millimeter cube, or people who fall within the WHO clinical stage in 3 or 4. That's for adults and adolescents. Every child who falls under the age of 5 qualifies for diagnosis of advanced HIV disease. We also try to categorize our diagnosis based on the affected systems. So for analysis, we use data version 14, and our proportions were calculated for the various diagnoses. Chi-square test was used to access statistical significance between our clinical characteristics as well as our diagnosis presented. And we obtained ethical approval from the Ethics Review Committee of the Kolebu Teaching Hospital with further permission obtained from the Department of Medicine and the Infectious Disease Center of the Korle Bu Teaching Hospital. So a total of 2,127 advanced HIV diagnoses were made during the period under interest. And we observed that based on the categorization into systems, we found that the three major systems involved were CNS-related diseases at 28.2%, respiratory-related diseases at 21.3%, and finally, gastrointestinal diseases at 18.4%. Here we have a pie chart which showing us the percentage of our distribution of our diagnosis with relationship to its systems involved. And like I mentioned, CNS, respiratory, and gastrointestinal systems were our commonest systems. So looking at our results, we find that for our CNS-related diseases, 58.3% of our patients were female, and 30% of our patients fell within the age range of 35 to 44 years old, with our mean age being 41.5 years, plus or minus 10.9. And our age range for all our patients was between 14 to 78 years. We also found out that 55% of the patients were newly diagnosed with HIV. Looking at the HIV types that we identified, we saw that 92% had HIV type 1, and only 0.5% had HIV type 2 infection only. So the overall mortality rate calculated for CNS-related disease as a whole was identified to be 66%. Now we turn into what CNS diagnoses were made, and the commonest CNS diagnosis we identified was cerebral toxoplasmosis at 79%, and tuberculous meningitis was the second commonest at 7%, while cryptococcal meningitis was the third commonest at 4%. We found that the most significant symptoms for cerebral toxoplasmosis were speech difficulties as well as fever, and that the mortality rate for patients diagnosed with cerebral toxoplasmosis was at 63%. I would like to point out that in our study, about only 30% of the participants had CD4 counts, and 83.6% of those who had CD4 cell counts already had counts less than 200 cells per millimeter cube. So to conclude, our study identified that advanced HIV disease is still common among HIV-positive adults as well as adolescents, and that CNS-related diseases were the most common advanced HIV diagnosis with a high mortality rate of more than 60%. We identified that cerebral toxoplasmosis was the commonest CNS disease. This therefore gives us the recommendation that the National AIDS Control Program, Ghana AIDS Commission, as well as other key stakeholders should ramp up HIV testing so that we can identify or to ensure early diagnosis as well as reduction of introduction to treatment so that we can reduce advanced HIV disease amongst people. And on a clinical level, HIV clinicians should have a high index of suspicion for cerebral toxoplasmosis in people living with HIV presenting with central nervous system symptoms. This is the end, but I would like to acknowledge my co-authors as well as staff of the Korle Bu Teaching Hospital Infectious Disease Center. Thank you.
Thank you very much. So kindly note down your questions. When this round is over, we would let her take it. The next presenter will be Prof. Jerry Ninoni, sorry. So Prof. Jerry is an associate professor of the mental health and the Dean of School of Nursing and Midwifery at the University of Cape Coast. Let's welcome him. He will be presenting on coping with loneliness and stigma among people living with HIV.
Thank you, Chairman. Good afternoon, everyone. I think we are tired now, are we? With your permission, can we just have some 15 minutes standing on our feet? Just 50 seconds, sorry, 50 seconds. 15 seconds. We came for our mental health, We'll be sitting for far too long. That is not good enough for us. Thanks so much for your permission. Yes, I'm counting up to 15 seconds, then we can resume our seats. Right. Okay, shall we resume our seat now, please? Thank you very much. Yes, we can settle back to our seat now. Okay, so I wanted to take you to a different level. Since morning, we've been talking about pharmacology, and the names alone can be very stigmatizing, isn't it? And we do know this is a community of stakeholders of mental health, HIV, and related stuff. And I will not worry so much going around with the prevalence. We all know it's about 2% since 2023. And we all do know that the medication we talked about this morning has a significant impact in the treatment of HIV. No doubt. However, it is still not curable. But the area we quite often don't look at it is actually the psychosocial component of HIV patients. If you are taking all the medication for the rest of your life, and the side effects and all that, that's going to have significant effect on your mental health, which is quite often overlooked. A common theme this morning has been stigma, stigma, stigma. Like I mentioned earlier, we have known there's reduction in infection rates in Ghana. A little is often looked at in terms of the psychosocial and the mental health of these people. So on that note, what we sought to do is to look at stigma and loneliness among patients that have HIV. And of course, if HIV has become chronic, you will expect that throughout their life, their quality of life in terms of their psychosocial well-being is still going to be affected. In addition to that, you will expect that right from the point of diagnosis, and for we have mentioned about the deficit in testing. And it's so because people are scared, are stigmatized, and are anxious about HIV. And of course, will not volunteer themselves for the testing. So right from the beginning, at the point of diagnosis, and throughout the course of HIV, there are huge issues to do with the mental health. Quite often, we don't look at that. So what we sought to do in this particular study is to look at the prevalence of stigma and loneliness among HIV patients. And this study was done in Cape Coast, in the Cape Coast Teaching Hospital. It is a cross-sectional study that took the form of sequential mixed method approach. 395 patients were recruited for the quantitative study and 18 participants for the in-depth interviews. Data was analyzed statistically for the quantitative study, and of course, thematic analysis was done to analyze a qualitative study that was taken. The population, all adults 18 years and above, were considered for this study, and the recruitment process was largely random sampling, except the qualitative, which we took a positive sampling approach. The main findings from this study, in terms of prevalence of stigma and loneliness, is not surprising because that has been the resonating theme this morning. Stigma accounted for about 99% from our sample. So quite frankly, the issues regarding stigma among the population group. And also, loneliness was found to be 30.1%. Gender differences in this sort of sample, there were not any significant difference between males and females. Other states reported otherwise. But in our sample, there wasn't any significant difference in terms of gender. But it's important we look at this 99.9% from our sample, which is almost 100%. It's worrying, and we need to really think about how we can integrate mental health services in the care for HIV patients. Number two, within that stigma, we did notice that internalized feelings of worthlessness public stigma and professional stigma were issues that were reported by participants. And of course, rejection, discrimination from family, peers, and society means a worrying trend among the population group. And when you look down on it, the professional stigma, again, is not just from the family, we ourselves as clinicians. It's results telling us that we need to look at how we can improve and reduce the stigma in terms of delivering care. And of course, it was just interesting when we started. The first time, conference, I realized that they were saying dignitaries should use the toilet. Other people should go the other side. It's quite interesting, isn't it? The first time ever in my life I've seen that happen. But at least culturally, we need to do a lot in order to fight stigma. So we'll get to that at some point. Number 3, comorbidities. People that have other existing physical health or mental health, where having increased likelihood of what? Loneliness. The higher the education, the less lonelier the individual becomes, which is quite clear on that. Stigma and self-image also positively correlate with loneliness. And of course, social support. You will have very little social support. That means that you're going to feel more lonelier compared to those that have some family or peer support in their communities. Social isolation, relationship challenges, and disclosure fears were actually some of the issues that were reported. And again, people were more concerned about their disclosure status, knowing that let somebody or community know that they were HIV positive. And because of that, they tend to keep it themselves and will not volunteer information because the fears of community being aware that they have HIV, that can't prove worrying to them. And also difficulties in finding partners, which is quite clear. Those who are identified are having HIV, although we know HIV is a chronic condition now, and with the right adherence to therapy, you can live productively throughout your life. The stigma, it doesn't take away the stigma. It's still a huge worry in our communities that of course have some cultural dimension. So when you identify having the virus, then finding a relationship, social isolation, and disclosing that information becomes a huge challenge for people to contend with. So all these kind of mirror relevant social and cognitive theories. Because you are lonely because they feel there's a deficit in social relations, social networks. And the cognitive theory suggests that people perceive deficit in relationship can translate to them having more lonelier status compared to others. We talk about inclusiveness. So we want to have some voices of some of the narratives coming from these patients, what they think regarding loneliness. As the first participant mentioned, which I know we can all read, I said before, I have not told anyone apart from my mother and siblings and my 2 uncles. Nobody knows, even my friends don't know, because I have this thing. I am not too public, although I used to be. I stopped outing, even not too public, although I used to be. I stopped outing even the beach. I quit going to the beach because of that. I have to be very careful. People think that if you involve yourself in prostitution, that's how you get it. So I was wondering what people will think about me when they know about it. I don't have Thai friends. I go to, or sometime maybe we meet at the marketing place in the morning, and then I go to my house. But go to other houses, I don't do that. So people have various reasons why they don't socialize or have community networks around them. One of the things that emerged from the qualitative study was the coping strategies. and predominantly housing situations, financial status, and self-reliance were some of the things that they use or become enablers in terms of coping strategies. Living or having the access to their own houses was seen as empowering and making them comfortable in where they are. But financially, of course, yes, the vast majority were actually not working. Those that were working, the majority were actually self-employed. And that again suggests that the stigma in terms of employability play a role. So more often, those who are able to be self-employed or have some gainful employment will feel a little bit more empowered to cope with their condition. So reduce reliance on others for support and enhanced coping. Of course, if they have these facilities in terms of financial and housing, they will be less dependent on others for help. And that actually will help their coping strategies. Number two are the support networks available to them. And commonly, family support was widely reported, peer support, healthcare support, and the community support as well. Religion and spirituality was quite dominant. And social network is not available. They find a ways of relying on the Bible to cope with the condition. And they believe that through that everything will be possible, especially if there's no cure. Religious communities also play a vital role in helping them cope with their conditions. The churches, the mosques, and other organizations were reported as instrumental in coping with those conditions. Faith. Of course, the belief, the value-based system we have, people believe that Almighty God is the only one that can possibly heal them. So there's significant cultural dimension on that. Strategy 4, concealment and avoidance were reported as protective factors. People choose not to report their condition. Because once we get to know that they have the condition, it makes them worse. They either will not interact with them. So the best for them to do is to avoid people or, disclosing their status as well. So having HIV from others to avoid stigma, certainly once they get to know, they will discriminate against them. So they will hide it. So clearly there are so many people out there who still have the condition. But because of stigma, they will never disclose that. Even when forming partners, that happen. And yet people are still not forthcoming about the condition. They're still not speaking about it. All because of the stigma attached to that. And if information, voluntary information, remains something else that we need to look at. So all these approaches kind of mirror the government theory, which looked about the discreditable identities. So we all pretend to be normal in order to be accepted. But as long as they get to know we have a condition, then discrimination comes in and they begin to avoid us overall. Strategy 5, most of them also engage in various activities to cope with the condition. Notably includes music, movies, and work focus. And again, very limited of them have work. So the few that have work preoccupy themselves with work and are able to cope with the condition very well. Role of healthcare providers. Although we attempt or we sometimes discriminate or stigmatize them, a lot of policies were reported about healthcare workers, largely in terms of the medical care. We mentioned a lot about the role of the pharmacotherapy, which they value and they think it helps them or stabilizes them. And they also appreciate the education and counseling they receive from the doctors and nurses they visit. And the counseling, emotional support were some of the things they find they were quite valuable and trusting building relationship. If they're able to trust and build you, they'll open up to you more and be able to discuss the condition with you. So professional or clinicians that are able to maintain this trusting relationship were appreciated by participants we interviewed. Some except from that, my mother reminds me to take my drugs and encourages me to eat well. My other siblings who stay at different places too, we communicate on the phone and I visit them. We interact well. I think the medicine because when you take them, you look good. Also, the way I perceive the disease, when I went for counseling and the teachings, the nurses made me understand that the disease is not as strange as people think. Again, my work also engages me a lot and makes me busy. I'm a teacher, so sometimes some student can behave to amuse you, which takes my attention from the disease. Right, now need for interventions. As I indicated earlier on, right from the beginning at the point of diagnosis, it is important that we begin to think about the holistic approach to healthcare. Yes, the medications are all there, but there's a lot happening. The literature suggests a number of people who are first-time testing for HIV actually end up either attempting suicide or completing suicide. So we really think that there's a need to have that kind of comprehensive assessment. And of course, develop that culturally appropriate mental health approach. We are all different, taking into consideration the demographics of the individual. Our religions, our life, our cultural situations are different. So it's not going to work for everyone. But we need to be sensitive to those cultural needs and be able to incorporate whatever intervention it is that can support and help the client in that regard. So the integration of the mental health service into HIV care is the message we want to drop down, because we tend to get preoccupied by the medication, by the other things. But the individual, holism is very, very important. What is going on in their life, they need that psychosocial assessment right from the beginning to help them cope with the condition better. And of course, that evaluation, continued monitoring at the point of diagnosis throughout the course of treatment can enhance quality of life. In conclusion, there are ongoing challenges, persistent stigma and loneliness among people learning HIV, like we mentioned. Everything else is reducing except stigma. Whatever we report, there's higher stigma. What can we do about that? Interventions. Culturally appropriate intervention is what we call for. So we need to be able to inculcate that right from the beginning. That will at least allow the individual to change their lifestyles or behaviors, and of course, actually adhere more to the medication we're talking about. But if we totally ignore them and not looking at their mental health states, then it's going to kind of be quite counterproductive. So identifying strategies that help them cope is pretty much important because everyone is different. What works for you might not work for me, and the vice versa. So we need to be able to look at those culturally appropriate strategies and intervention that prove to work so that we can encourage them to resort to those ones to at least alleviate some stress and stigma. Future research will need to still focus on developing and evaluating targeted psychosocial intervention, which is the mental health we're talking about. We cannot undervalue that component. Anything else we do, the individual are not committed to the treatment, then it's bound to fail. So we need to encourage and look at that strongly right from the beginning and developing some intervention guidelines actually involving the mental health in the treatment of people with HIV. Thanks so much. We acknowledge some people that have made this possible, and then I'll take any question at any time. Thank you.
Thank you very much. Let's do it again for questions. So we will take the last
presentation in this round of the oral presentation. Then we'll take the questions. So the last presentation will be on data quality review of HIV linkage to antiretroviral therapy and retention in care in health facilities in Ghana. So the presenter is a public health nutritionist with experience in epidemiological research, managing and coordinating public health projects, monitoring and evaluation of programs and scientific communications. She's also proven competencies in strategic coordination, planning, administration, and management of project activities. Her research interests are child nutrition, maternal and child health, and infectious diseases. She is a scientific writer for Ghana Field Epidemiology and Laboratory Training Program, where she leads all the scientific communications activities. She coordinates nationwide surveys and international research. She's currently a PhD candidate in the University of Ghana. Ladies and gentlemen, let's welcome Ms. Dilia Kosiabando.
Thank you. Good afternoon. We've had a very long day. I'll not take too long. But in all our discussions that we've had today, I think one thing has come out clearly. All of this has been because of research, and research comes with data. And clearly we know that if there are data quality issues, everything that we come up with our research would not be able to make very good projections out of it to cause the changes that we need. So what I present here is a data quality review that was done. Please, can you hear me? Okay, great. Sorry, I thought I got it. Okay. So we are looking at the data quality review of HIV linkage to ART therapy and retention in care in some health facilities in the country. So just as a background to the study that was done, HIV data is very important. We are here because over the past 20 years, a lot has been happening and most of it has been based on data. And then to be able to know the quality of data that you have, there are different dimensions that you can look at. So we can take a look at the various concepts, that is looking at completeness of the data, the timeliness of the data, consistency of the data, or the uniqueness of the data. Those are some of the data quality dimensions that you can take a look at when you're analyzing data. And it is the same with HIV care too. Once your data is poor, you don't have reliable estimates, and then whatever projections you are making are not good enough to be able to make the change that you need. WHO recommends that, their policy framework recommends that for every institution or for every program, it is good to have occasional evaluations internally. Aside that, it's also good that you get an independent person to come in to do an evaluation to really be able to tell you whether the kind of data that you are generating is good enough or things, or there are things that you need to take a look at. And looking at the linkage rates that we have in Ghana, even as at 2021, it was low. That is 59%. What that actually means is that we are not achieving our 95 targets. And so the quality of the data that is generated is very, very important. And that is what necessitated carrying out this study, to be able to identify what are the problems that are leading to this low linkage that we have. Are there data quality issues that we need to take a look at? And what are the things that we can solve? So this was a qualitative on-site verification exercise. It was done as part of a bigger study to find out why we are having such low linkage rates. So what we did was to review programmatic data in the health facilities, that is looking at all the reporting tools, and then speaking to the people who do the reporting to find out what the challenges might be or what they think might be accounting for these low rates that we are seeing. So how were these facilities selected? The facilities were selected by zoning the country into 3 based on the 2021 linkage rates. So all facilities, zoning the regions of the country into 3. So all regions, which had about 80%, were termed as high, and then randomly one region was selected, and that was the Western region. Then those between 60 and 70% were termed as medium. Then one region was randomly selected, that was the Greater Accra region. Then the regions which had less than 60% were termed as low. So for that, we had one region selected, and that was Central region. In each of the regions that we selected, what was done was the regional hospital was selected as a site, 2 district hospitals were selected, and then 2 health facilities were also selected. To be able to know the continuum of care which goes on in all the facilities in the country, 1 tertiary facility was added. because looking at the regions that were selected, tertiary was missing out, so the one tertiary facility was added. So it means, we had 16 facilities that the data quality review was done in. So data from all of the source registers were extracted to find out that, so when someone comes in, what are the processes the person goes through, and then what is the kind of data that is captured? Where is the data captured? And after the data is captured, what happens? After this review was done, then we spoke to the people who did the entry, and then who handled all of this to find out that, so what are the challenges? Why are these things that we are seeing? For the data quality dimensions that we looked at, the ones of interest were completeness. We wanted to find out, so this information that we obtain, how is this data entered from one point to the other? So if it's if it's written in the registers, from the register, where are the places that it is reported to? And is it fully reported? Then how often, like what are the timelines of this data that is reported? Is the data timely as it's supposed to be, as a program request? And is there duplication or uniqueness of data? And we also found out whether there was data accuracy, finding out if there were any inconsistencies in the data that was reported. So after we got this information, basically proportions were calculated and the interviews that we did were transcribed. Then with the data quality dimensions, we tried to assess to see how good the data was or what the issues were with the data. All of these responses were then triangulated with the interviews that we had held with the staff to get a better understanding of exactly what the issues were. So in total, from the data extracted, these were the number of people who had been tested, so the number of positives and then the number which had been profiled. So you see that some of the bottlenecks that were obtained in the cascade was the number who were not profiled was quite high. So about almost 44% of the people who were tested were not profiled. Once they test, they don't profile to find out whether they're already on ART or they've actually tested positively where before. And then you see that about 20% were also not referred to treatment, though they had tested positive. One of the things that we also found out when we took a look at the metrics was data incompleteness. So of these 16 facilities that were assessed, about 75% of them had data incompleteness. And then what was happening was new people, we had new patients who are put on ART. The information is captured in the register, but the information never gets into eTracker. It ends there in the registers. And then timeliness of data, about 20% of the facilities were not reporting the data monthly as they were supposed to. There was duplication of data. So you see one record entered a number of times, showing in eTracker. And then for data accuracy, they were trying to see that the information that is entered might be wrong for some of the patients, even though that is not what it's supposed to be. So in speaking to the people to find out what the issues were, some of the things that came out clearly were inadequate offices. So we had a facility telling us that there are no people to do the entry. And because they need to enter, they just get anybody. The people don't even understand what they are doing, but they've been asked to enter, so definitely they'll give you something that you ask them to do. And then there was also very poor record keeping when it comes to entry into eTracker. So these were some of the things that they mentioned were issues that were affecting the data quality that they had. Okay. So to end, you can see that in all the facilities that we were in, there seemed to be some data quality issues. Some were systemic. So for example, eTracker, they also mentioned that you can enter some of the information into, you have some of the information in the ART registers, but if you want to enter into eTracker, there's no section to capture that information. So then what happens is the information stays in the registers and never gets into eTracker. And then that shows that there are systemic issues that actually need to be addressed if we really want our data to be of good quality, to be able to make the kind of projections that we want and to get where we need to be. And then additionally, the timeliness was also not the very best. The timeliness was not the very best. What it means is before data gets to them, it's going to take a very long while. And whatever decisions need to be made on time will not be able to be made on time. And there was inconsistency in the information that was provided. So clearly, these are some of the things that were accounting for the low linkage rates that were seen or that are currently seen in the country. So we recommended that NACP engages the health facilities, especially those who do the data entry. So for example, sits down with e-tracker, understand what exactly the issues are, how best can we solve these issues, so that we can get the information that is needed. Some of these recommendations are things that could be which could be done instantly. So for example, finding very simple verification methods within the facility so that helps with verifying the information or the data that is entered. And then another recommendation is through the Director of Public Health to engage HR to see if we could get more staff to help with the data entry. Because the data is collected and the data is not entered, it really doesn't help us. Because basically what it means is all the information, all the hard work that we are doing, we don't really get to do anything with it. So these are some of the recommendations that we gave from the work that was done. And then I want to acknowledge NACP, all the facilities and then staff to support them with this work.
Thank you. So we'll take the questions now. If you have a question, kindly put up your hand and okay.
Thank you very much. My comment is on the presentation by Dr. Property. Yes, that was on the advanced HIV disease. And you realize that most of your population was inpatients. I think the challenge is that, I've forgotten what years, but WHO stopped us from doing CD4 test. So now to diagnose advanced HIV disease, you have to use WHO stage 3 and 4. In those clinical stages, patients are very, very ill. In a study done by Tope, myself some time ago, I think, I can't remember, it was 2004, we found out that I think 40% of asymptomatic patients have CD4 counts less than 200. So I think that the challenge here is that because people are asymptomatic, we think that they don't have advanced disease. And because we are doing test and treat, and also because we don't use CD4, I also realized that certain co-trimesal prophylaxis has stopped. So I think that to reduce the mortality, we should go back to co-trimesal prophylaxis, because those days we gave co-trimesal until your CD4 was 350 or more. So these are some of the repercussions of some of the policy decisions that we have taken. I know that we are bringing CD4 testing back here. I don't know when you are going to populate all these, what do you call it, 176 ART sites or whatever with CD4 machine. But my recommendation is that even when we have asymptomatic, what do you call it, patients, we should remember co-trimesal prophylaxis, because that is many years ago. Even 40% of those who were asymptomatic had CD4 counts less than 250. Thank you.
Thank you, Prof.
Somebody can repeat that study now. Find out.
All right. I want to ask a question on the data quality review. Yeah. One thing I've realized is that there are some of the reports that we do. My name is Adam Daniel from Food PDM, St. Elizabeth Catholic Hospital, Health Information Officer. One thing I've realized is that some of the reports that we do, what we have on DIMS and what we have in the registers, they are different. We've talked about this several times. Review we do, but we are not hearing anything about it. For instance, the early infant diagnosis register. We've not heard anything about it today. And also there are other facilities, there are most places that they don't even get access to bundle to even do the entries. That is also an issue. We've also talked about that. It's still not coming. There is also another issue that I've also realized. E-Tracker was updated recently, and it's been 3 weeks now. It has not been updated 100%. There is a facility that has about 1,000 clients. Clients in a clinic day can see about 60 to 50 clients. The review, the follow-ups are piling up, and there is just one data officer. There are most facilities where all the NACP data officers who were employed, most of them have left. Have there been a follow-up to check who is now doing the work? So that is my little contribution. Thank you very much.
Thank you. Any more questions or contribution? Okay. All right.
I've always wondered why, again, with respect to the programmatic issues and the systematic issues, why we keep on having the same issues over and over and over again. And I think that's something that we should look at. It's not just for NACP, it's for the various other programs. I'm just making a comment out loud.
Thank you. Thank you very much. Responses? Okay, thank you. Thank you very much. Let's look for all our presenters as well as our moderator, Dr. Pai. Thank you for moderating this session. So I will invite Dr. Evelyn back to continue. Stick to our time. We want to finish everything before we close and go for our lunch. So please let's bear that in mind. Thank you. Over to you.
Thank you very much. I think we've been sitting for a while, but I know the next two brief presentations. The first one is a discussion. So we are going to discuss the research agenda. Let me get the correct topic title. Okay, so we're discussing the national research agenda for HIV. And to lead us to do that, we'll have a presentation from Professor Alexander Menu. Alexander Menu is an associate professor of epidemiology and disease control at the University of Ghana School of Public Health. He's a medical doctor, a statistical epidemiologist.
It's okay. It's okay.
It's not okay. It's not okay. Let me finish.
It's okay. Thank you. Clap for me.
No. It's not okay. They don't know you. Let me say a brief things about you. Yeah. So he's interested in his public health has been focused on leading and supporting countries and institutions in Africa. He's interested in endemic diseases.
I'll tell them.
Maternal,
I'll tell
newborn, and child.
You know what? She's my mate, so she'll want to say it, but I'll stop it because I'm coming to have a dialogue. Thank you very much for introducing me.
Alex, I haven't finished introducing you.
I like where you are. Okay, so I'm coming to have a dialogue. I'm not coming to do the usual presentation, so you must all be awake. Because if you are sleeping, I can call you. So if we haven't listened to what we have listened to from the morning till now, if I ask you what should be the research agenda for HIV control in Ghana, what would you say? Any volunteers? I normally give chocolates to people who respond to my questions. Yes.
Okay, so my name is Robert. From what I have listened to so far, I think we should be looking at the two drug combinations and then the oral acting, long acting treatment medications. We should have research topics in those areas. Thank you.
All right, so research on the medications? Yes.
My name is Ivan Spencer. I'm also thinking more should go into the area of stigma. Because if you have the medication, we have everything in there, people affected are not ready and willing to go for it because of the stigma associated with it. All the efforts would go with. So I think more effort should go into the stigma and discrimination aspect. Thank you.
Brilliant. Any more? Yes, Elizabeth.
So I believe that we should look to the community and see what they want, and then we can have some research into it.
If you're not looking in my face, I will call you. So please be looking at me so I can. Can you pass it to you?
Thank you so much. I also think that we should look towards finding research towards skill, which is very important. That's also
very, very biased. Okay. Yes, but we need cure. Yes. One last one.
Yeah, thank you very much. I think I liked the presentation on mental health a lot, moving away from just a singular focus on medication to the individual and to their lives. So I think mental health will be a critical research area for me. Thank you.
Thank you. And the last one.
Thank you very much. So I want us to look at the acute shortages of logistics to work with, the logistics that we need to work. I think it's very, very important why certain services are not being rendered at certain places because of lack of logistics. Thank you.
Who recorded all the things they said? Those of you who talked.
Improving on our data.
Improving on data. Ladies and gentlemen, thank you for the time. I've finished my presentation. But this is the dialogue I'm supposed to come and have, right? We know the challenges, don't we? We know that we need to move research. If we talk about research, the goal of research is to solve problems, right? Who doesn't know the problems we are talking about here? But you realize that if we want to solve problems, then sometimes we have to be generating new knowledge on how to solve them. Sometimes we are doing certain things, but we don't have understanding of what we're doing. We just got the allusion to a data person entering data that they don't understand. Right? If you ask me to capture data on stillbirth, a baby that was born dead, and I check, and the baby's heart rate was measured as 132. Once I don't understand, I will enter that. But the baby was born dead. Right? If we need to move forward, if we want to move the research agenda, we need to be intentional. And that is what I'm going to tease you with. Because I'm a hardcore epidemiologist. And I believe that data makes a difference. And we need to move from listening to what people tell us from elsewhere to generating our data and using our data to inform our policies. I don't think we need a lot of money sometimes to be able to do operations research. That I am an arts clinic providing services to people. I want to just know whether my clients are happy with the services or not. That shouldn't come with money. But the information we get from there is critical. I'm using the Gen Z thing, critical. All right. So normally when we look at research in 3 domains. I was told to come and talk about the research agenda, but I'm sorry to disappoint you because I want you to set the agenda. The first domain that we normally look at is discovery, then delivery, and development. What do these mean? Yeah, normal book long things. So when we talk about discovery, we are looking at what new things can we learn, right? Our colleague was talking about how do we even cure HIV with epigenetic factors, right? The gene is here, another gene is here, in between is the epigenetic locus. What can we do? Because we now know that genes can be switched on and switched off. So I am shocked and I'm bored because my daddy decided to switch off that gene for tallness and hair. So he's looking at that as a focus to cure disease. What new things can we learn? The other thing is delivery. Whether we know the new things or not, we are still doing some things. How do we improve the implementation of the existing interventions that we know have been tested? Right? We know that services for young people is effective. How do we maximize or optimize the delivery of services to young people? How do we use platforms that will reach young people in a way that is non-discriminating and non-stigmatizing? And then the last one is development. And that is where innovations come in. We need to think about the usual way of doing things may not help. And we are all guilty. We are all guilty. You are invited for a meeting and it's Ghana meeting. So if they say 9 o'clock, you should leave home at 9. But you know that traffic will take you an hour to get there. The same way of doing things will not give you different results. Those of you who like football, I support Arsenal. So when we had Arsene Wenger in Arsenal, he was using the same method and wanted to get different results. It doesn't work like that in life. We need to change and innovate. So I'll give you some few teasers to see why we need to be thinking differently and look at things differently. There are gross inequities and inequalities in even the prevalence of HIV in Ghana. If I ask anybody what's the prevalence of HIV in Ghana from today's meeting, what would you say? Some people didn't come here. Did you give them lunch coupons? Can you claim them back? Right? 1.74% was reported. Most people were saying less than 2%. But when you hear this, it makes you feel that if you have 100 people or 1,000 people, 17 of them will have it. But it depends on where you are standing. So you can see that if you look at commercial sex workers or female sex workers, it's about 18%. And if you look at MSMs, we are looking at 5%. And not just that. If you look at people living in rural areas and people living in urban areas, these numbers might not be accurate, but what I'm saying is that these differences exist just by personal characteristics or place of residence. Is this difficult to think about? How can we make services reach people in poor areas as much as the rich areas? Then we come to gaps. 53% suppression among adults, 47% suppression among children. But it's the adult who will take the child there. So what's the problem? How can we reach these children? Then the thing that I like most today is stigma. 30% of people do not adhere to ARVs. And so, our epidemic can't stop because people are still taking it. If you suppress your viral load to levels that are undetectable, you can't pass on to people, right? But if you are not adhering to ARVs, then you pass on to your children and you pass on to other people. And that is a challenge, right? Elimination of mother-to-child transmission. This has been talked about, so I'm not going to waste your time. But I am the one that they called the consultant, unfortunately. But I have no good news, because if you think about hepatitis B, syphilis, the transmission is going on with HIV. Because if you have syphilitic infection, it's just any sexually transmitted infection, it increases your likelihood of getting HIV. If you have HIV, it increases your likelihood of getting syphilis. When Prof. Topo was presenting in the morning, he said that tenofovir is one of the diseases and drugs that can be used to treat hepatitis B. So if you have hepatitis B and HIV, why do we not think about integration? So integration is possible. And co-infection is around 8 to 12%. This thing doesn't like certain things. I realize that. And then another thing that I picked today, which is not only something that I am hearing for the first time, is the issue of non-communicable diseases. And they are so intricately linked. How many people here, I have got friends who come to me and say, look, the way you are talking, I should check your blood pressure. You check your blood pressure and high, you say, oh, because I just came to this place. You know, when you said you wanted to test it, my heart was beating, so that is why my pressure is high. People feel that chronic diseases are stigmatized. If somebody has diabetes, it's stigmatizing. When people have hypertension, it's stigmatizing. So if you're on ARTs and you become chronically ill with HIV, stigma is going to be there. But how do we learn from, because HIV stigma started from us. Initially, it was called a killer disease. And anything that kills, people shy away from it, right? And then we got that stigma coming in. But now, we want to unlearn that stigma. But if we are successful with HIV, we can extend the knowledge or extrapolate it to affect other diseases that are around us. What mechanisms are we putting in place? So I'm already raising research questions that I think that we can answer. I talk about stigma. And the worst part of stigma is the fact that the stigma, 39% of HIV, people living with HIV, feel stigmatized in hospitals. That is 4 out of every 10, 2 out of every 5 people. Unpardonable in the hospital, right? I don't want to talk about younger people because for them it's even worse. And because of that, they are not going for their medications. Data. I didn't read their slides before coming. We did independent work. But you see, we are all saying the same things because we all know the same things. Data-driven monitoring and evaluation. We want to know what is working. How are we progressing? E-tracker is being implemented vertically in many countries. Should we also do the same in Ghana? So there's an e-tracker for HIV, there's an e-tracker for Family Health Division, and those e-trackers don't track. And they don't talk to each other. There's LIMS. How can we improve data capture in the e-tracker? Suggestions have been made from the presentations. But for me, it is a research that will move the suggestions from the level of a suggestion to the level of implementation. That is what I want to know. We've made so many recommendations. If you look at master students' dissertations in the University of Ghana, thousands of recommendations. But what are we doing with them? And these are people who went to their villages or small towns around Ghana and made research that have brought out findings. Can we even do a meta-analysis of these existing research and say, pulling everything together, what do we know and what can we do differently? Digitization, mobile telephony. If we don't have the young people on, look, when we started, look, these things are here. I am lucky to be one of the people who started life when there was no internet. And I would die when AI can cook for me. So I know what difference it makes. Sometimes I sit down and I'm thinking, and I feel I know what my daughter is thinking. But I realize that I'm completely wrong because she has a completely different view of the world from what I have. She doesn't even understand what I'm talking about. It doesn't even make sense. And I think she's being stubborn or she doesn't respect. So we need to get to their level. And you can't make programs for young people when you don't have them involved. And I see NSCP engage young people in many programs. But again, we should think about domesticating these things and making them sustainable. So how do we do sustainability? We need research. Readiness for the future. I wonder what future is. Because some years ago, I used to call today future. Now, I am living my future. Tomorrow doesn't exist. So how do we prepare for that future they talk about? Clinical readiness. Are clinicians ready to tackle HIV? Are they ready? We've talked about coltrimoxazole or Septrin. Septrin is so common and so cheap. Are we ready to take care of our patients properly? I mean, if you are at the workplace, whether you are paid well or not, you are there. So why would you not treat the person who comes to you well? Because you are there anyway. Whether you are paid well or not, you are there. So there are things that we need to think about differently. My boss is here, so I have to be careful how I talk. The other thing is public health readiness. Yes, we are talking about the clinical part. We also have to think about the public health part. When a person comes to you in public health, we don't think about an individual. Somebody comes to you with a snake bite, and you don't think about how the person is going to die, but you are thinking about how many other people can get snake bites from where this person is coming from. A different way of thinking. And then the next one is, do we have infrastructure for research? And when I talk about infrastructure, it's not structures. Sometimes it's in people's brains, right? We have stalwarts here, like Prof. Tope, like Prof. Lati. We can't let their knowledge go with them. We need to sit at their feet and learn. Those of you who are Christians, Jesus was on earth to save mankind. For 30 years, he was a carpenter's apprentice. Then he did his work for 3 years and died. So apprenticeship is important. The Gen Z sometimes don't understand that. But we need to get that into our heads again. Testing options, availability, accessibility, in a way that is acceptable. Then have we thought about herbal remedies? One of the most, when you talk about cure, I thought you were going to talk about Nana Drobo. Some years ago, we had a famous herbalist called Nana Drobo who said he had discovered a cure for HIV, and then he died. I don't know whether he died of HIV or not. I mean, that was Noguchi who died of yellow fever, but Nana Drobo, I'm not sure. He traveled to Japan without an aircraft. That's how powerful he was. But what I'm basically saying is that we need to also start thinking about herbal remedies. Because if you look globally now, you go to hospitals in the UK and they are offering you acupuncture as a treatment option. Right? Can we help develop our system? So when I saw some of the posters there where they saw candidate agents that could be used for HIV management. I won't say cure, management. I think we need to be giving them attention. But how do we support them? Because sometimes the challenge is that unsupported, they kill your kidney. Supported, they can support you. So have I brought any research agenda here? No, I only came to tell you the problems you already know. But what do we need to do then? We need to think about conducting a research prioritization exercise, particularly for HIV, because this is a case in point. We are currently doing something similar for newborn health, maternal health, child health, and nutrition in the country. But we need to think about doing something like this. But it should be an inclusive process. It shouldn't be only experts sitting down to think about it, because the expert can think about the solutions, but me sitting in my village knows how I want the service to come to me. So we need an all-inclusive process, use objective approaches, not subjective and also think about defining a defined scope of what we want to do. So if we want research prioritization for HIV control in Ghana, we should be clear what our objectives should be. Because when you have research prioritization and you can prioritize what are the things that you should be tackling first in Ghana, it brings a clear focus and rationale for investment cases. So people make investment case and then you get investment into that. It also increases your investment and it brings accelerated program progress. So you can pull people along. You see, we are pulling 20 years along. I was born in a town called Agomanya. Agomanya is still in my passport. When I was going to do my passport, they said, oh, change it to Accra. I said, no, I was born in Agomanya. Agomanya is very famous, and everybody mentioned Agomanya today because some time ago we had the highest rate of HIV in Ghana, and I was proud about that. I was telling everybody that has put us on the global map, not for positive reasons. I was also lucky when we were starting ART at the Kolebu Teaching Hospital Fevers Unit. I happened to be a house officer at the time. So I have seen some of these footsteps and I've seen how we have grown. The stalwart sacrifice for these, and we need to also follow suit. But as I'm saying, we need to go into research. What approaches are possible? One approach that people have used is the Delphi method, where you are just building using consensus from people. So several rounds of emails you send to them, what do you think should be the areas that we should, or you select the areas, you say which ones are important, they come back to you, you go back to them. The second one is the CHINRI methodology. CHINRI is Child Health Nutrition Research Initiative. It is similar to Delphi, but it introduces some level of objectivity into it. Because after you've even got the research ideas, it brings people together and asks them, how will you rank these ideas? And you give them criteria that they should use, like effectiveness, potential for impact, equity, and things like that. So once you have those criteria, they use them to score. And by that, you can prioritize the research areas that you want to work in. So, what I'm worried about is that the future generation is looking up to us. I don't have research ideas that are put together to come and tell you. But what I want us to do is that we must have an all-inclusive process and have everybody seated here and other people elsewhere involved in setting the research priorities for HIV control in Ghana. Honestly, without research, we will not get where we want to get to. And the research could be in all the areas that you cited: data, stigma, new drugs, and everything that we've talked about today and beyond are critical to moving this agenda forward. So I haven't come with a list, but I have come to provoke you to be part of that thinking process to look at research priorities for HIV control. The time to act is now. Thank you very much.
Thank you very much, Prof. Menu. If we have questions, we'll have time for it soon. We have one last presentation. It's going to be very brief. Okay, so he's leading us in a research protocol, behavioral approach to weight reduction among overweight or obese persons living with HIV in Ghana.
Yes. Good afternoon, everyone. I'll be very brief with my presentation. So I'm here to just briefly share a proposal that's actually in development, okay, looking at the non-communicable diseases amongst persons living with HIV. Now, one thing we are all here celebrating is the impact of ARVs in reducing AIDS-related deaths. And UNAIDS published that as of December 2023, AIDS-related deaths have reduced by 69% since its peak 20 years ago in 2004. One thing that is happening is that recent evidence shows, although we are keeping them alive, their quality of life is in jeopardy because non-communicable diseases are really hurting them. Looking at an assessment of insurance claims made from an insurance company, we notice here that comparing persons living with HIV to those who are not living with HIV, the incidence of these cardiovascular outcomes amongst persons living with HIV is higher, relatively higher than those who are not living with HIV. And this is what is one of the agenda Prof mentioned about the non-communicable diseases, especially the cardiovascular diseases amongst persons living with HIV. Now, in addition to the traditional risk factors for the cardiovascular diseases, including age, sex, diet, smoking, and all that, HIV and ART-associated factors have been found to lead to inflammation. They lead to inflammation, impaired glucose tolerance, and adverse lipid parameters, as well as direct toxicity on their clients. And all these culminate in leading to endothelial dysfunction, which is one major precursor for these NCDs in persons living with HIV. Now, one other way HIV or antiretroviral care leads to NCDs amongst our clients is through weight gain. Now, ARVs have come to change the face of HIV from weight loss or from wasting to weight gain now. And this has been found to be due to the effect of the ARVs in reducing opportunistic infections and thus reducing the catabolic effect of the virus on the clients. And the metabolic effects of some of the ARVs also lead to weight gain in our patients. But some of our clients are overgaining weight, putting them at risk of these non-communicable diseases. Now, one major candidate, or one major molecule that is contributing to the weight gain in our clients is the, sweetheart we've all found, that's dolutegravir. Evidence has shown that there are so many mechanisms through which dolutegravir is leading to weight gain in our clients. One is its influence on the melanocortin pathways, leading to increased food intake in our clients. The other is through its influence on resistant gene polymorphism, causing derangements in insulin metabolism in our patients, all leading to weight gain. Now, Ghana introduced the dolutegravir in 2019, as Vincent presented earlier. And before we started enrolling clients on them, there was a cohort study that part of which Vincent presented. I'm proud to enrolling clients in the study. We assessed their baseline body mass indices. So even before they got exposed to the dolutegravir, which we know causes weight gain, we found out that almost 50% of them, about 48% of them, were already at risk of this non-communicable disease because they were either overweight or obese already, even before they got exposed to the dolutegravir, which causes the weight gain already. So we really need to talk about weight management in our persons living with HIV. Now, in addition to increasing their metabolic risk or their risk of acquiring these non-communicable diseases, the weight gain is a major contributor to the failures along the program's outcomes. We noticed here that, or from clinical engagement, we noticed that clients are disengaging from care because they know the ARVs they are taking is leading them to put on weight. We know people are switching back to their previous regimen because they are, gaining weight. Some are not adhering well. And due to the weight gain and the stigma of weight gain that Prof mentioned about people's mental health or persons living with HIV are having mental health issues due to the weight gain associated with the medications they are taking. So it's really a conversation we need to have. So this study being planned or this protocol being written is to help develop a study that will help us determine the effect of a behavioral weight loss intervention, amongst persons who are living with HIV. We see whether this intervention will help or not. And specifically, The study is to help us develop a weight loss intervention package for the persons living with HIV, and this will be done through qualitative and quantitative approaches guided by behavior change theories. Following this package development, this will be tested over a 12-week period to assess its effect on dietary behavior or the dietary behavior of the study participants. It will also assess the effect of the intervention on the physical activity levels of the study participants, and overall find out whether it has any influence on the weight and other cardiometabolic profiles of persons living with HIV who are either overweight or obese. And the plan is to have this done as a quasi-experimental study in 2 ART sites in the Greater Accra region. And it is hoped that after this study is done, we will have evidence to develop a national weight management guideline or protocol for persons living with HIV who may have these weight challenges. We have, and when this is implemented, we have improvement in the lifestyle of these persons in terms of their diet and physical activity level. And when all these work, we hope this will help reduce the burden of these non-communicable diseases or cardiovascular diseases amongst persons living with HIV. Thank you very much.
Thank you very much, Dr. Edu. He's with the NACP, and he's the pediatric and adolescent health focal person for the clinical care unit. At least let me say something small about him. Thank you very much for the presentation. So the agenda is not set, but we have been provoked to set the agenda, and we have been told that we all need to get involved and we need to prioritize the research areas to be able to do it. I don't know whether we are going to come together again. Maybe at our individual basis, we'll start the process of engaging, raising the agenda, and then PM will call us together to come and prioritize and see where we start or where we actually progress to. I'm not so sure. But 2 minutes, if you have any contributions or questions for either Prof. Menu or Dr. Edu, please, we can take it before we bring the session to an end. Anything. I feel like it's a challenge for us to think wherever we find ourselves about contributing our quota to the research agenda. We have to be intentional, as he says. We know the questions, we know the problems. We need to begin to think of how we can solve them, either using new approaches, improving on the existing ones, or maybe collaborating with others to get the job done. Any hands up? I can't see any. Anyone with a comment? Okay, I think at this point, my job is done. Let's push the research agenda because data is everything. Data will help us to solve all the problems that we know exist. But we need to do the research to generate the data. So I'll just add on to what Professor Menu has said. Let's think research wherever we find ourselves. Let's actually do the research and provide the data to enhance the lives of the people living with HIV in Ghana and beyond. Thank you all for cooperating with me.
We can do it better for 2 times or later. Thank you very much for moderating this session. This is just in a series. We hope to come back here or maybe a better venue next time to look at the research that is still ongoing in the area of HIV STI. Thank you so much. So we are gradually coming to the end of today's activity, and I'll call our chairperson, Prof, to give us his closing remarks. Please help me welcome Prof. Tope.
Thank you very much. I think it's been a long day and packed. And I must say that this has actually been beyond my expectations, especially the posters that we had. It actually shows some of the good research that we are doing across the country. In terms of my remarks, I'm going to be brief and straight to the point. because I started with the discussions of the evolution and where treatment is going. And one of the lessons that we have learned, especially from the elimination of mother-to-child transmission, was the need for integration and also making sure that our programs are decentralized. That would be very, very critical. Then one area that has been recurring throughout this meeting has to do with non-communicable diseases. And it looks like for a person living with HIV, you are more likely to die from a non-communicable disease than the HIV itself. So this actually calls for urgent steps for us to try to be screening for some of these conditions, and then also have interventions to address some of the risk factors like we just discussed. Because diabetes, cardiovascular diseases are all major issues. One coming from lifestyle and also from the drugs that we use for treatment. And then in terms of latency reversing agents, I really hope that this is an area that we need to do more research. I mean, a lot of work has been done on latency reversing agents to try and tease them into the bloodstream and then use drugs to kill them. But we've not had very good results. And I hope that in 5 years' time, Abanes Lab will be able to get us something exciting. Advanced HIV disease. This is also a very important area because you see, we started treat all. But the reality is that we are treating everybody, but we are still finding people who are coming in late. So we really need to engage more. People really need to know their status, because a lot of the people who come in late do not need their status, and then they find out when they are symptoms. So we need to really do more so that we can get, I mean, the first 95, we can get more people into the pool and then offer them treatment. Then mental health. Mental health is a very, very, very big deal. And a lot of times we really underplay it. And I think it needs to be at the forefront. Stigma drives mental health challenges in our clients. So we need to be able to screen for mental health. And fortunately, there are tools that we can use to identify mental health challenges so that we can address it in our programs. Then the big elephant in the room is data. We need data to drive our intervention. So if we are having challenges in the data, we need to take a step back. Because otherwise, all the things that we find, especially from the programmatic side, if you take decisions based on that, you may not get the results because the data itself is problematic. So we really need to take a good look and see how best we can improve the data. And of course, like was mentioned, there's a lot of verticalization, and there's a need to integrate all these. And I really enjoyed the research agenda, the way it was couched, and I think this is really important. All of us, every one of us, must really think through what can we do in our small way to advance the 95-95-95 agenda. And some of the solutions will come from this country. And I think we need to do that. And like you said, the time to act is now. And then the work on the weight loss. This is interesting. I mean, this is something that 20 years ago, nobody would have thought about it, that HIV and weight loss, really? Are you serious? But it is. So how do we address this within our program? I mean, from the advanced study that was done in South Africa, there are a lot of issues with obesity. And we are also seeing it here. So how do we reduce the risk factor? Because you see, the issue is that if you treat the HIV and the person is virally suppressed and the person dies of stroke, basically, but the total work done is zero. And I want to ask to reflect. My final statement is what the Director General told us when he started. He said, our work is far from over. We need to support Ghana's progress to improve in the areas that we've been found wanting. And then we also need to strengthen prevention. as a pillar in the treatment program. This is what I'll leave with you, and I really thank all of you for your contribution, and for those online, really thank you very much, and I hope that we'll keep working and we'll keep talking, so that in the end, we'll all move towards epidemic control of HIV. Thank you very much.
Thank you very much, Prof. Chair. So I will invite Madam Josephine Boateng from the NACP office to give us the vote of thanks. Please have the welcome here.
Hello, everyone. I'm honored to deliver the vote of thanks at this maiden National HIV STI Research Dialogue Series on behalf of the Ghana Health Service and the Planning Committee. Our utmost gratitude to God Almighty for granting us life and a clear weather to a successful event. We say Ayeko to the Planning Committee and the organizers, Prof. Tope, Dr. Isiado, Chief Nat, the consultant, and your team. Your dedication and meticulous planning has ensured the smooth execution of this event. Our heartfelt gratitude to Professor Kwesi Tope, the Dean of School of Public Health of the University of Ghana, for chairing this gathering to a fruitful end. Prof. Akpekakaka, your leadership and passion towards the fight against HIV cannot be overemphasized. Dr. Patrick Kumagwaji, the Director General of the Ghana Health Service, we are indeed grateful to you for delivering that enriching keynote address. We are most grateful to Dr. Franklin Asiedu-Bequin, the Director PhD, for sharing the purpose of all this important gathering with us. We extend our sincere thanks to the MOH, Ghana Health Service, the Ghana AIDS Commission, UNAIDS, UNICEF, UNDP, UNFPA, PADP, UNOPS, PEFAS CDC, Abortina Plus, Garnet, for their partnership and collaboration. We appreciate the invaluable sponsorship from Viatris and WHO. Your generous support has been instrumental in making this event possible and successful. We hold in high regard our distinguished oral and poster presenters. Indeed, your presentations brought to bear knowledge and insights into the collaborative efforts at fighting the HIV menace. Best Western Premier Hotel, God bless you for your hospitality and service. Indeed, we felt comfortable and welcomed. Our friends from the media, we appreciate you for covering this enriching experience to share with the world. And to the rest of us, our moderators, participants, attendees, volunteers, both physical and virtual, you've been awesome. Your active participation and engagement enriched the discussions, making the HIV STI Research Dialogue a memorable and impactful experience. Thank you all once again. We wish you safe travels back to your various destinations.
Thank you very much. Madam Josephine is the head of administration at NACP. Thank you for that. Please handle your coupons well. I've been told the lunch is not being packed, so please go. Let's all go to the restaurant and take our lunch over there before we leave here. So once again, thank you so much, those online and those of us here in person. Thank you for staying with us throughout the period and even for going your lunch for a later time. Thank you so much. Enjoy your lunch, and we hope to see you once again for another interactive session like this. Maybe 2 days or even more. We hope so. Thank you so much. We'll take the closing prayer. Any volunteer? Any volunteer? Thank you.
Shall we pray? Father God, we are grateful unto you for a successful program. We thank you that you granted us the ability to be here and to participate in all that we deliberated on. That even as we move these talks into action, we pray for your guidance and we ask that, Lord, your hand shall be with us even as we develop a country free of HIV. I pray, committing everybody going back home into your hands, and ask that Lord, your protection shall be with them. In Jesus' name, amen.
Thank you. Enjoy your lunch and see you another time.